Okay, Borodar, croeso to this meeting of the Hywel University Health Board. Just a couple of things to say before we start on the meeting. First one being that we did hold an in-committee meeting first thing this morning. The items from that meeting are available on the Hywel website, and we will be, so people can see the items on the agenda. Thank you. Few people to welcome to the meeting today. First of all, I'd like to welcome Eleanor Marks, our Vice Chair, to her first meeting of the board. And I'd also like to welcome Michael Gray, who is the Local Authority Social Service Representative from Pembrokeshire. Welcome to the meeting, Michael. Also, just to say that this is the first board meeting with Professor Butler as the Interim Chief Executive, Lisa Gosling as the Interim Deputy Chief Executive, and Mr. Mark Henwood as the Interim Medical Director. So I think I've captured everybody. Please don't be offended if I've missed you out. So thank you very much. And we have apologies, I'll move on to the agenda now. We have apologies from Jeremy Hockridge, who's our new chair of the Stakeholder Reference Group, who unfortunately couldn't be with us today. So I will now move us on to the main agenda. So first of all, can I ask for any declarations of interest? Chantel?
A few items on WISC on the agenda today.
Okay. Can you
speak? WISC.
Thank you.
Can I declare an interest in item 4.5 concerning the LAN practice? I'm registered with Coach and Horses in St Clair's.
Thank you.
I'd like to declare an interest. I've got a close family relative on item 4.6 with the Tumble and Cross Hands surgery.
Thank you. And
I'd like to declare anything.
Speak up,
Sorry.
please.
I'd like to declare anything in relation to industrial action, but doesn't trade union rep.
Thank you.
Diolch, Cadeirydd. I'd like to declare an interest in respect of 4.5 LAN. I was part of an earlier committee looking at the decisions to be made around it, and I will recuse myself from that discussion.
Okay, thank you. Any other declarations of interest? No? Thank you very much. So if we can move on to the minutes of the meeting. First of all, the public meeting held on the 25th of January. Are there any items anyone wants to raise for accuracy, correction on those minutes? No, thank you. Declare those as a correct record. And then we have the minutes of the corporate, the trustees meeting, sorry, so I put the wrong thing, minutes from the trustees meeting. Anything on those minutes? No, thank you very much. And then I'm moving to the matters arising, and they are there for your information, but there are some items which I think haven't been completed, so I'll deal with those first before asking for any questions. The first one of those is on page 2, item PM 2414, and Lee, I wonder if you could give us an update, please.
Yeah, I can take both those.
Microphone.
I can take both those together, if that's okay, 2014 and 2015. So essentially we've completed the first one, but what we'll be taking forward is each of the schemes will be QIAs, and then the detailed proposals will be forward planned into the SRC work plan. So they're obviously in different stages, so they'll be coming through SRC once they're in that position to be progressed.
Okay, thank you. And then there's also an item at the top of page 3 related to the paediatric service implementation.
Yeah, that's fine. So update is programmed to go to the SDOC agenda, SDOC meeting in April, and then the point in relation to the membership, that's been completed and needs to just part of the update to SDOC as well.
Okay. Thank you very much. Thank you, Lee. So, going back to the start of this, can I ask if there are any questions on any items? Maynard?
Yeah, thank you, Chair. PM 23-220, the item at the bottom of page 3 and page 4 of the report. Slightly concerned to learn that we don't have accurate information about DNAs in the GMS. We're often cited as an area of pressure that we've been relieved of being have so many DNAs, and what this is telling me is that we don't actually know how many DNAs we've got in primary care. So I don't know if anybody wants to comment on that. Just flag the concern on that one.
Okay. Jill, can you?
Yeah, I think, thank you. What I can say is that practices do collate their own DNAs. You'll often see on the desk when you go in the number of DNAs missed on this month. What we haven't got is a national system that records this on that basis. I think we would be able to have that information through our dashboard for our managed practices, and I know that we've been talking about developing our dashboard and being able to implement that across all of our independent contractor practices as well. So we would hope that we would have that system at a health board level, but we're still waiting for a national mechanism to be able to report that. But it's really important, I think, and I think for members of the public listening today, I think it's a really important issue in terms of being able to manage the capacity that we've got within our GMS services effectively, and so that if people aren't able to attend for appointments, then they do let their practice know.
Second point on there, PM 24-22 on risk 1708. There's reference there to a RAC survey report being due imminently about whether or not that the RAC side of things needed to be identified as a separate risk. I'm just wondering if we've got any update on whether that report's been delivered or not.
Yes, thank you. We submitted a report to Welsh Government as we were expected to in collaboration with our estate system, and we reported it on the basis of the feedback that we'd had from all of our contractual professions. And just as an example from a GMS perspective, we had 65 premises, 47 of those reported no RAC, 6 of those were awaiting surveys, and 12 we had no responses for. We've got similar responses then for each of the contractual professions. So we have submitted that to shared services and Welsh Government, and at this point I'm not expecting to identify a separate risk unless we have any confirmation coming through from what are the nil responses at this point, and that suggests that RAC has been identified in any of those premises.
Okay. Helen?
Just to point on paediatrics, please, on Lee's response, is just to ensure that there's still patient experience going on throughout this period and through the implementation stage. It's just seeking assurance that that is happening, really.
We're continuing with the...
Lee, can you
Sorry.
speak?
Sorry, I was just clarifying the question.
Sorry,
Continue
so
with patient
experience in paediatrics, because they're still travelling to Billy Bush.
Sharon might be better to answer that question. I don't know. The paediatric surveys the surveys we were doing of the paediatrics patients. Do you know if we're still doing that?
We still do the paediatrics part, maybe not in direct relation to the but every month we include as part of the patient experience report.
Yeah.
And my second one is the continuous engagement with those service users while going through the implementation stages. Take assurance that will happen as well.
And we've got service users as part of the implementation group, so yes, they are part of that. Yeah.
Okay, thank you.
Okay, thank you. Thank you. Okay, there's no more questions. I'll move on to my report. Just a few things to highlight there. You'll see there's been an item of Chair's actions, which we'll come to at the end. I also just wanted to, as I would always do, congratulate all our award winners that are detailed in the report. And also a thank you to all those who've received long service awards. It's always, I know fellow IMs always report as well, the stories that we hear when we present these awards are actually incredibly inspiring, and it's a real pleasure to do that. I would just like to just highlight something that's not there in the report, but I think everyone will be aware that we have The ministerial appointments have been made, and the Cabinet Secretary for Health and Social Care is Leonard Morgan. And we have a new Minister for Mental Health and Early Years, that's Jane Bryant, and a Minister for Social Care, Dawn Bowden. So just to note those appointments who will be dealing with the Health Board. You'll see on the final page of my report that I can confirm that we have now had an appointment as a new chair of the Health Board, and that is Dr. Neil Wooding, who will be taking up his post in June. So I'm really pleased about that, and I will be making contact meeting. We have been in contact meeting with him after the Easter break, and you'll also see the new associate member updates, which I referred to at the start. There is one thing I'd like to add, which sadly is not pleasant news, and that I would just like to note that we were very sad to hear that one of our very respected retired surgeons sadly died at the beginning of this month. That was Mr. Withanangi, who some of you will be aware of. He worked at Withybush for more than 40 years and has had an awful lot of input into the services at Withybush. And I think a lot of staff were sorry when he retired, but actually very sorry to hear of his passing. So on behalf of the board, I really want to pass on our condolences to the family of Mr. Withanangi. So thank you. So I'll happy to take any questions on my report. Okay, no questions. So if I can move us to the recommendations to support the work since the previous meeting, and in particular to ratify the action undertaken by myself, which are detailed in the appendices to the paper. Everyone content to do that? Thank you very much. So I will now move on to the report of the Chief Executive.
Chair, sorry,
Oh, sorry.
we're getting really bad feedback on the live stream. I've just had a couple of messages from
Okay.
the public. If anybody has a phone on the table, can you just move it away? Sorry to ask again.
Okay, so it seems to be, can you take them off the tables,
It's feeding back. Sorry.
not just near the microphone? Okay, thank you very much. Just check mine's not there. Right, thank you. Phil.
Okay, Bordar, good morning. This is my first Chief Exec report, and there are a number of things to highlight. I think the first thing I wanted to highlight was what I felt was a really positive whole staff engagement meeting. Thank you to the comms team for setting that up, and the exec team for supporting, and those for attending. So I hope that will be a regular fixture where we'll be able to communicate and connect with staff. Staff were able to ask us questions as part of that, and I hope we'll do that every 6 to 8 weeks with staff. Second thing to highlight is the new revised executive team arrangements that we're putting in place, performance management arrangements to respond to our targeted intervention status, to make sure that we're ready to respond to that challenge, and those arrangements are being put in place rapidly for April. Third thing to note is we were really pleased to sign the corporate parent charter, which a number of organisations across Wales are signing up to. We signed that on the 18th of March, and it really does promote responsibility to safeguard the rights and chances of children and young people who have experienced care. So delighted to be part of that, and for our organisation to be signing up to that. Also highlighted in there is for approval are the virtual pooled fund arrangements for adult care home placements. That's important. We've had that in place for some time. You'll see that the recommendation is that we approve that proposal for the next year. And The next item I wanted to highlight was emerts, which I do think deserves particular mention. There's been a huge amount of work undertaken by ESCA and all the health boards and directors of governance to progress this work. The Emergency Medical Retrieval Service is a really highly specialised service that only responds to about 1% of 999 calls when people are in real difficulty. And it's not a service that is called upon directly by the public. It's called upon by Welsh Ambulance team when they're on site. There have been a number of meetings of EAST since 2022 when their proposal to improve services was made to EASC, and there was a meeting, as you'll see in the Chief Exec report, where we met on the 19th of March and considered the engagement so far, which included the results of the Phase 3 engagement and also the EMERT service review. We were also presented with 4 recommendations which are in the report, and we also discussed all of the feedback, including a letter from Llais. In the meeting, we recognised 2 things, 2 really important things. One is that we needed more time to consider the information. In particular, we recognised that we needed to respond to Llais, and the Chief Ambulance Commissioner wrote to Llais on the 19th of March, and I know discussions are ongoing with Llais. We also asked, as all the Chief Execs asked, that there would be more work undertaken on recommendation 4, which is additional service to reduce unmet need. At the moment, there is unmet need across Wales of about 1,000 people who don't receive the Emergency Medical Retrieval Service, who we believe should do. The whole of this programme of work is about reducing unmet need. So because we need that more information from Llais and more discussion with Llais, and because we needed more work undertaken on recommendation 4, we are meeting this evening as EASC to consider the further work that's been undertaken by the team, and we have a process where we will meet, we will have a board meeting we're setting up on the 10th of April, where we've asked the Chief Ambulance Commissioner to come and give us a brief directly, so as board members we'll have the benefit of that, before the proposed joint committee meeting on the 23rd of April, when we will meet again as the former EASC, which will move into the joint committee arrangements. And then we will take the final decision back to our board in May. The last thing I wanted to say on that was about the important role of the Welsh Air Ambulance Charity, who are absolutely instrumental in running this service for the population across Wales, and recognise that how difficult delay is in us reaching a conclusion in this matter for the charity, and also just recognise the work that they've done over so many years for our population. So the last thing I wanted to mention, Chair, was about phlebotomy services at Antioch, at the Antioch Centre in Llanelli. We know that there's been, there is significant interest, of course, from the Llanelli population in phlebotomy services in the community. We recognise that from feedback from the public that we do need to improve those services. Also that if we're going to make service change, we recognise that we do need to undertake a period of engagement with the public. And also, at the moment, in the meantime, services will be provided at the Antioch Centre for phlebotomy. Thank you.
Thank you very much. I'll open it up now for any questions. Helen.
Yeah, I was just wondering if the Health Board could make a statement on the Antioch press release, because we are inundated in Cais on phone calls on it. So if they know it's going to continue there until there is a public engagement, that would be helpful.
Yeah,
please,
we did send, one did go out, which I noticed was included in press releases yesterday, but there's no reason why we can't issue something in relation to what's been said here as well.
And I'd just like to thank Alwena for coming in regarding the engagement. And Cais would expect an 8-week engagement period, but that can be discussed outside this meeting.
Okay, thank you, Helen.
Yeah, recognise the significant public interest in that service in Llanelli and the important relationship with yourselves as Cais and us in terms of working through what engagement would be required. And we are working really hard with the team in Llanelli to make sure that we have the right services for people for phlebotomy in that area.
Thanks, Phil.
Okay, thank you. Any more questions?
Diolch, Irene. Diolch, Phil. Just a question about service user involvement with EMIRTS. As we know, we are quite a rural patch, and I would think that part of the 1% retrieval for the air ambulance is in our rural area. So do you know exactly how the public will be getting involved?
Yeah, so we've had 3 phases of engagement so far, and so the results of the engagement survey were presented at EASC, that completed phase 3, in fact, at the end of February, and so the results of that were presented to us at EASC, and the looking at the percentage of feedback across Wales, 5% of the feedback was from our population, just over 5%. So, and when you look, of course, at our population, the concern generally will be from North Ceredigion. And we do need to recognise also that we're part of the Mid Wales Joint Committee. We've got a long-standing relationship with Betsy Cadwaladr, Powys, to consider the population needs of Mid Wales. And so the feedback from the Powys population and also South Gwynedd population, I think, is also very relevant to us as well.
Yeah, thank you. Any other questions for Chief Executive? No? Oh, Michael.
Sorry, just for clarification then, so on this East point, so is the final decision then coming up, or because you're getting more information, it's not a final decision yet, but that's imminent?
No,
That's
so
next month.
So we are, so today we are not being asked to make a decision because, as you say, there is more information, so there's more discussion with Cais, and we need to conclude that. We also need to, as an EASC body or the new joint committee, receive more information on recommendation 4, I believe, before we can make a decision. So that's my recommendation to our board, that we need that information. Now, we will have more information presented tonight, and I would hope that at the board meeting on the 10th of April, we will be reaching a conclusion on those matters and be able to make a decision.
Yeah, that is the intention of the meeting on the 10th of April, that there is enough information to enable this board to make a decision on the outcome.
I suppose just to add, all boards are meeting, all health boards are meeting the 9th, 10th and 11th of April, subject to sufficient information being provided to EASC this evening to enable that to happen. And then following all boards meeting, that output from the 7 health boards will then go to the Joint Commissioning Committee, hopefully to enact then. Those are the dates. The 23rd is the dates that have been committed to for the charity.
Right, that's really hard. Actually, my question was going to be that all the stakeholder boards have to be meeting around the same time,
Yes. Yeah. Okay, thank you. So if there's no more questions, if I can turn to the recommendations on page 6. We're asked to endorse the registered ceilings, note the status report of the consultation documents, approve the changes to the scheme of delegation that are outlined, approve the pool fund agreement, and receive the update on the EMIRTS service, including noting the letter from Cais. Is everyone content with those recommendations? Thank you very much. Thank you very much. So if we can move on now to the report of the Audit Risk and Assurance Committee. Rodri.
Thank you, Chair. Obviously, this report summarises the work of the committee held on the 20th of February. As always, we had a very full agenda with, as always, plenty of scrutiny. I take it that I'll take the report as read. Just a couple of things that I picked out here. If you look at the internal audit, there's a lengthy meeting that we're going to have in April. There's a lot of a lot of work to go through, but as always it's interesting and it's important to give as much scrutiny to every one of these kind of topics, so it's no doubt it's going to be a long meeting. If you look at the audit tracker, there is one typo there. It is, if you look halfway through, it says the number of recommendations that have gone beyond 6 months of their original completion date has increased, so it's not reduced, from 47 to 66. And as chair of the committee, I've asked for a letter to be sent to all directorates to make sure that all those risks on that audit tracker, that they are all looked at, and how many can be closed and how many need to be addressed. Therefore, that is something that is ongoing. If you then just turn to, firstly, regarding matters requiring board level consideration or approval, well, the terms of reference for ratification is in Appendix 1, and then a risk management strategy for approval, which is 2.6.1. And if you look at that, there are kind of noting 3 new objectives of risk management, which is implement and embed the Health Board's refreshed risk appetite statements, support the strengthening of operational risk management arrangements, and understand how established risk management processes currently contribute to the overall health of the organisation. This strategy was developed following recent consultation, including with all board members, and was presented to the ARAC on the 20th of February. Just a few matters of concern which I just want to highlight. The financial assurance report and the need for a change to the scheme of delegation. The requirement of an extraordinary ARAC and board meeting in public in mid-July to sign off the annual report and accounts for 23-24 due to Audit Wales' timeline to complete financial audit work, which also impact on the Health Board's ability to hold the annual general meeting by the end of July 23 in line with the standing orders. This has now been scheduled for the 26th of September 24. The challenges and risks, such as the lack of capital funding and the uncertainty of Welsh Government targets affecting the Health Board's ability to effectively progress with Welsh Government's decarbonisation agenda, where it was highlighted it was a limited assurance internal audit. That is something with the financial situation we are in. We have to look at these aspects in detail. Also, with the Mental Health and Learning Disability Directorate, provide assurance on their progress against recommendations raised in the Audit Wales review of operational governance arrangements. Concerns were noted on the number of outstanding recommendations owned by the Mental Health Learning Disability Directorate on the Health Board Central Tracker, and due to lack of assurance provided in management responses, the requirement for a number of reports to be brought back to the April committee meeting. That is my report. Thank you, Chair.
Very much. Thank you. Any questions? No? Thank you. Thank you very much, Rodri. So if I can ask us to formally approve the terms of reference, yes, and the risk management strategy. Okay, it's agreed. Thank you. So if we can move on to item 2.7, which is the report from the Quality, Safety and Experience Committee, and this is a new format which we hope to take forward with all committees. Hannah.
Thank you, Chair, and as you've just reflected, this is in a new format. We hope it simplifies the key messages coming from our committee discussions, which we recognise are often very detailed and complex. So we hope this new approach to reporting to board will be helpful and will help to sort of fine-tune attention in the right places. So just to run through the 3 different categories we structured the report around. The first is for any items to alert the board to, and I'm pleased to report that on this occasion there are none of those. The second, where we do have a set of issues, relates to the need to advise the board, and this is where we think there's an issue that might be bubbling. We've got actions in place. We will confidently track those actions through the committee, but they could at some future point require escalation to board. And then the final category is to assure, and that is where we are satisfied that while there are issues that need to be addressed, plans are in place and have a realistic prospect of resulting in a positive outcome. So that's how we get to the alert, advise and assure. I don't think I need to say anything more about that. I would just like to highlight an excellent piece of work that was undertaken through Sharon's team, particularly under the leadership of Cathy Steele, to provide a learning review of the nosocomial COVID review programme. It was, the committee felt, an excellent piece of work, really a gift to the organisation that has the potential to offer messages of learning that go beyond the specific subject matter, and for that reason we really wanted to put a challenge back into the organisation to think how this might be a blueprint as to how we take learning and spread it across our organisation when we have valuable messages to share and spread and embed. So we're looking forward to hearing in 6 months' time how that challenge has been responded to, and feel very optimistic about that opportunity that we have through this excellent piece of work. Happy to take any questions, John.
Thank you very much. Any questions? Oh, Maynard, sorry.
Yeah, thanks. Love the new format of the report, much clearer. Thanks for piloting it. On page 2 of 3, there's a section there on interventions not normally undertaken. And it's concerning that we actually might be paying for things that have no effect and not paying for things that are effective. And I'm just wondering, do we have a time scale for the task and finish group? And is it, I believe this area is also being looked at by CDG in terms of financial aspects as well.
I think that might be a question for Mark, perhaps. Mark?
Yeah, thanks, Maynard. So there is, as you can, you're right to bring this up. It's a really important point. There's a lot of work going on nationally and within the Health Board to look at what we call in-use. We'll be changing the name of in-use. It's not a really good name. In England, there's been quite a lot of work on what are called evidence-based interventions and developing good evidence for a lot of these interventions. A number of these interventions we do undertake because it's appropriate to undertake them. The issue is, when should we undertake them? We will be working with all directorates, and directorates have done a lot of work themselves. We have had quite a lot of assurance that we aren't undertaking many in-use. So I think there are related issues to this in terms of coding, how we identify the procedures. But suffice to say, there is a lot of work going on in this area, and I can't give you assurance specifically about every single intervention, but we're working very hard on it.
Okay, thank you. Any other questions, Michael?
Thanks. I was interested on the bit about...
Michael, sorry, could you just...
Right, on page 2 again, about the operational governance point, and is that purely in a kind of clinical context, or does that cut across other aspects? Because that was something would be is that if it did, then it's interesting, of course, to the other committees as well. So I just wondered, my ignorance maybe, but is that right? Is that clinical, or is that more wider?
Defer to exec colleagues to cover that.
So sorry, Chair. So the conversation, Michael, was about Andrew's operational structure in terms of the governance that we have within the organisation in terms of the operational structures, which, as we know, will be changing. Andrew and I were talking only yesterday with his new structure, how we get a consistent approach across the whole Health Board, and in that, then we probably would need to look at the role of Squeezac, because that kind of sits in a place that maybe we need to have a look at when we go forward. So it wasn't about the board and the committees where the committee had concerned. It was about what support we can then put into Andrew and his teams to get a consistent approach operationally across the Health Board.
Andrew, do you want to come in on that?
Yeah, no, Joe's articulated that really well. I think the other point was the operational kind of that replacement to operational quality and safety committee also ties back into some of the work we're doing as an exec team around the governance review that Phil's been undertaking in terms of subgroups of exec team and how all of that reporting works. So I think all of that will come together in April. On the operational structure, if you mentioned it, I was going to mention it later. I did issue that last night, my final version of that last night to the operational team, so we'll now be looking to progress that over the next few weeks, and happy to talk to her, and I'll share that, but happy to talk to anyone about that if there's any questions or queries. But it is my intention that in establishing that we have a really standard and consistent approach to governance that sits alongside it, which I think that structure will help facilitate as well at that point.
Thank you very much, Andrew. It's possibly precluded a question that was going to come up later, so thank you. Any other questions on this paper? Yeah.
Can we just thank Anna for piloting this AAA report. Winston gave us the idea, so we've used a model that we've looked at and tweaked to help out. But thank you to Anna for again agreeing that we could try something with quality and safety to improve our governance, Chair.
Yeah, thank you. We'll record that, and also thank Winston for bringing it to our attention. And I think we'll be taking that forward with all the committees. Thank you very much. Okay, so I'll move us on to the next part of the agenda, and that's the update on this year's annual plan. We have to keep reminding ourselves we are just still in the year 23-24. Lee.
Thank you, Chair. That is correct. Yeah, so I'm happy to present this update on behalf of the executive team. Board members, of course, very aware and familiar with our plan for this year, 23-24, and the planning objectives contained within it. Each planning objective is overseen by one of the committees, health board committees, and updates were presented to the February committees on all 23 planning objectives. A summary of the status is presented within the paper, and some further detail within Annex 1, which I hope is helpful. In addition to that, of course, we have deep dives within those committees, which we programme in at regular intervals and therefore available publicly and are contained within the committee updates to boards as well. So we are, of course, revising our planning objectives for next year, which will come up in the next item. So I wasn't going to say much more than that, other than to say that the intention would be that we'd have a closure report, as we've done in previous years, at the next round of committees in April, and then that'll come to board in May.
Okay.
Thank you.
Thank you very much, Lee. Questions? Colin?
It's how you, can I ask how you're going to communicate what you've accomplished and what you haven't accomplished, and why you haven't accomplished it to the public in layman terms that they understand? So how's the health board going to do that?
Okay, I think so. Obviously, the reports we get to committees and to boards are intended to present that information, and the annual plan update does summarise what we've for next year. Does summarise some of the benefits from this year. I think it might be there's a question for us, which Alwyn and I are considering at the moment, about how we create a more public-friendly document that might allow us to both summarise the learning from this year, but also describe our intentions for next year. Because obviously at the moment it's written with a certain purpose in mind, which I think we can probably make more public-friendly. Agree.
Okay, thank you. Maynard.
Thanks, Chair. In the table on page 2 onwards, there's a number of items that are recorded as behind. Twofold question. When you look at the detail in the table, some of those have Q4 dates associated with them. Some of them are still saying that they're not going to be complete by the end of the year. So wondering, on the Q4 dates, are we still confident that we're going to hit those targets? And 2, on those that we don't hit, I'm assuming that those objectives will be carried forward into next year's plan, which we've got coming up in a couple of minutes.
So on the first part of that, if it's described as behind, then clearly there's expectation that we're not likely to make the Q4 date as we'd originally set out. I think we'd have to go into each individual one to really describe what that means. But broadly, that's I guess the expectation. And as a reminder, of course, we revised some of our expectations through the November board meeting and so on. So these are the updated positions. In terms of actions that are not completed, so yes is the simplest answer to that. They're within the detail. There could be some elements where we might have concluded that we can't proceed with them for one reason or another, but in the main they will carry through into this year's plans, and that will be a critical part of the closure reports that come through April and May. We'll clear, as we've done in previous years, whether we're then not going to proceed with anything that we previously said, or what the revised plan is.
Okay. Andrew, do you want to say anything? Because I know some of them were in your area.
Yeah, no, and I think probably what I was going to come in on follows on from what Maynard asked and what Lee was responding with. I think there's particularly on some of those relating to my area and that sit with me, I think there's the reflection of a number of the actions are complete and on track, and we've delivered some of the changes and improvements we wanted to put in place, but actually the performance, so the outcome from changing that process or that system isn't necessarily where we wanted it to be when we set our trajectories at the start of the year. So it's that sort of nuance for some of my areas between actions being taken and delivered, but not necessarily having delivered the impact in performance terms that we would have expected, which we will cover when we get to the performance report as well, as members will know.
Okay, thank you. I can't see any other questions, so we're asked to note the status, and I guess note that there will be discussions in the April round of committees, and then a closure report will be brought to the May board. Okay, thank you very much. So we'll now move on to the year we're soon to enter. Lee, the next year's plan.
Yep, thank you, Chair. So I think everyone around the table is very familiar now with the position regarding the development of our annual plan for 2024-25. We obviously discussed it a number of times at board and board seminar, as well as some of the committees. So I guess the key starting point is we are, of course, unable to produce a financially balanced plan again for this year, for 23-24, and indeed that has been the case for every year that the Health Board has existed. So, as this paper notes, this is a breach of our statutory duties, which is a very serious and unacceptable position for us as a board to be in, and of course has been a significant factor in our escalation to targeted intervention. I think I know, and we all know, that the board is determined to address this. We also recognise that the Health Board has some long-standing workforce, estate and service fragilities, which means addressing the situation and the scale of the challenge in front of us will take time and will require some fundamental changes. I think when we look at the item we've just covered and some information within the starting the early part of the annual plan document, you'll see that we are on a path. We are on that path. So we have seen some reduction this year in our nursing vacancies, nearly 130 full-time equivalent improved. That has allowed us to eradicate off-contract agency. We've seen some improvement in through transforming urgent emergency care programme and community care, which has reduced the number of long-stay patients. And we've seen overall improvements in most performance areas. We've also, of course, established the clinical services plan, and we made a significant decision in November around acute paediatrics. And that's that the clinical services plan, of course, is later on the agenda. That said, I think we all are very much aware that that progress is insufficient, and we continue to have a substantial financial deficit, which obviously we'll cover now in the discussions, and our patients do continue to wait longer for care than we would wish. That, in part, is because of some of the challenges we've got around duplication of services and spreading our staff too thinly, and there is an over-reliance then on medical staff, medical locums, high-cost medical locums in a number of areas, which is also on the agenda later. So the plan we are presenting today, we are acknowledging does not solve all of these issues, nor does it address them quickly enough for any of us. What it does do, however, is firstly start to deliver continuous progress in year one. So we are expecting to arrest the deteriorating financial position that we've had over the previous years, and we are looking to further improve performance, further reduce our nursing vacancies, and secondly, beyond year one, what we're describing here is a plan that sets the foundations for a route map to addressing some of those more fundamental issues, not least a route map to the control total in the first place. So we're clear, I think, that as part of that journey we will need to develop a coherent set of plans for clinical services over the medium term. That is a theme that comes through in all of our discussions in this agenda itself, actually, but certainly within the planning round that we've just gone through. The planning round has reinforced the importance of the clinical services plan, but it's also evident from that process that even the extensive list of services we have in the clinical services plan, and we've got that later, will not address all of those concerns and issues. So we are expecting, therefore, a need for a broader exploration and development of the medium-term clinical model, as is noted in the paper. So I suppose, just to summarise, I think the plan is ambitious and will be challenging for us to deliver. We know some risks within that. Nonetheless, we're accepting it doesn't meet our expectations, particularly in relation to financial deficit, and therefore some further urgent action will be required over Q1 and Q2 as we start to develop that trajectory back to the control total in particular, but also progress against all the other elements that I've mentioned. So I'll hand over to Hugh at that point, if that's okay, to just take us through some of the specifics in the financial plan.
Yes, it's an extraordinarily difficult financial climate within which we operate, and firstly I'd like to thank colleagues across the Health Board for supporting us in developing a plan in that challenging environment. It is the result of a number of difficult conversations that we've had across the organisation, and thanks to colleagues for approaching them in an open spirit. And also thanks to Welsh Government as well for the financial settlement that we've had. This is the first year where, as we go into next year, the additional costs which we see and foresee in our plan are covered by the additional funding that we are getting, and recognise that also Welsh Government have kept the risk of pay awards as a centrally managed issue that they will further address. We have benefited from next year being a lower inflationary environment than the one that we've had over the couple of years that we've just been through, but it remains a really good settlement, and a settlement that has protected health to a large extent. However, the issue that we are facing is one where our current deficit is the one that we are bequeathing to next year, and the one that we'll be inheriting as we go into next year. And we are spending more than the Senedd have voted on, and consequently that is a regularity issue and a breach of our statutory duty. Some of the key issues that are driving our position, our expenditure on secondary care continues to significantly drive our cost base. Recognising that secondary care is part of a broader system and is challenged by the demand that we're seeing at the front and the flow through that system, with additional challenges from staffing, inflation and drugs. But last year, our 4 sites just on unscheduled care overspent by £19 million. We made that good in the budget coming into this year, but this year again, those sites are further overspending by £15 million, and we're having to make that good again in our budget going into next year. But this isn't a new story, and despite our best intention over a number of years to shift services into the community, our resources, relatively speaking, in an unplanned way, shifting back into our hospital services. So if we go back 10 years to 2014-15, 48% of our budget was being spent on by last year, 57% of our budget was being spent on hospital care, and 29% on community services. So there is a challenge in how we plan to deliver services which does compensate for that impact that we have seen. Page 33 of the plan goes into a bit more detail on the position. Our plan as prepared will see us with a projected deficit of £64 million for next year. It's a very nominal improvement, but a stabilisation on our current projected deficit for this year of £66 million. Despite that nominal improvement, it will require us to deliver a very significant level of savings, £32 million. That's largely because we didn't deliver the stretch target this year to get to our control total of £11.3 million of savings, and the full year impact of our existing financial performance adds a further £45 million to our cost base going into next year. So some real challenges for us to address. At this stage, I can see a path for us to get to about £16 million worth of recurrent savings and a further £10 million of anticipated non-recurrent savings. That's £26 million in total against that £32 million requirement. So there's a further gap of £6 million that we need to identify and deliver, and we'll be working on that, as Lee alluded to, at pace during Q1. It's an uncomfortable position, I recognise, for us as a board. In proposing that deficit of £64 million, with that known gap that we have, and balancing the need for us to drive further improvement with urgency, with the assurance that we have on what we think we can deliver as an organisation. However, I want to reiterate the point that Lee made, that this isn't a particularly acceptable position for us as a board. We are spending more than the Senedd have approved by £64 million, and we're spending more than Welsh Government have indicated through their control total by about £20 million. Currently, we don't have cash coverage for that difference at this stage, and that represents clearly a risk that we'll be managing through the next financial year. I do expect Welsh Government to conclude that our plan isn't affordable because of that cash issue as much as anything. And that's why the recommendations have been drafted in the way that they are. It recognises that we do need to approve a plan in order to allow the Chief Executive to delegate budgets from the 1st of April and allow us to continue to operate from then. But Q1 is a key period for us to de-risk the plan, as we've got to focus now on delivering what we've set out and then drive further improvements to close the gap back to our control total with urgency. So, Chair, I'm sure there'll be discussion as a result of this, and I hope the recommendations are relatively clear.
Okay, thank you very much, Hugh. Right, I shall open it up to 2 questions. Who'd like to start? Helen?
After reading the plan, and I can see that you're going to outsource some of your clinical activity, and it's about reminding to get patient experience when you're outsourcing to another health board or private or wherever you go, is to get that feedback from those patients who are going. And my other question is, so what does this mean for the patient? It doesn't actually tell the public what it means for them, simply. So what does this plan mean for the public and the patients that are using the service? Because that is not clear in there. And it's about having maybe an executive summary, so it would help the public and patients understand what they can expect for the next year within the health board.
Okay, who wants to take that?
I'll have to take the second point, certainly.
Yeah.
So on the second point, so obviously within the plan it sets out a lot of things that we're doing and what we expect that to translate into in terms of performance improvements, etc. But I'd acknowledge it's clearly written for a board and for Welsh Government and so on. So I guess the point I made earlier is the relevant point, which is there is an opportunity, I think, to think about how we describe this in layman's language, if you like, so we can present that to the public, which is not something typically we've done before or the health boards have done before, but I think that could be a good innovation for us.
And then my last question is how the public have influenced your plan. Have you looked at the data and complaints? Have you looked at patient experience? And how the public have influenced this plan and what's important to them?
Yeah, if I just quickly respond to that. Okay. So obviously we've had a bit of this discussion before, so clearly obviously our plans are based on our risks, our complaints, our patient experience feedback, that all comes through in the content of the plan. And I guess the other point to make in reference to this is we've had a good opportunity over the last 12 months to engage with the public through both the land consultation and the paediatric consultation, and in general those conversations have been quite wide-ranging. They've not been isolated to those two topics, so that's really allowed us to get a sense of where the public are on some of these questions, and that's influenced some of our thinking within the plan.
Okay, thank you.
Andrew, come in on that.
Yeah, I was just going to pick up the outsourcing question and the patient experience. I'll link with Sharon, but absolutely we'll make sure that's something we collect. It's certainly something we've picked up as we've been going through some of the clinical service plan deliberations in terms of the issues paper that's on their agenda later on in relation to that activity that happens for our residents outside of the health board, and how we include that in our decision making. So we will pick that up. I just wanted to say as well, if I could, Chair, just to, I guess to stress the although within, I think my colleagues have said, but although within this plan, it looks like there are a number of areas we do not get to in terms of target performance, ministerial priority, we should not underestimate the operational challenge in delivering the scale of change that's going to be required to demonstrate improvement on all these fronts, which the plan does deliver, even if it doesn't get to some of those target levels of performance. There are opportunities in there for us still to go out around efficiency and productivity, which we can push harder, I think, through the year as we get confidence in the plans we've got. And certainly I think around some of our elective waiting times, there's opportunity there with some of the work we've done in the last month across the health board. But I just wouldn't, I think it's easy to look sometimes at where we're going to land against a set of measures that we're going to be measured against and think, well, that's not good enough, and I think we'd all accept that we're not getting as far as we would want to, or making the progress we'd want to make next year. But I think being able to progress to the degree we're outlining across that full suite of issues and areas is going to be is not an unambitious ask of the organisation within the context that we're operating in.
Yeah, thank you, Andrew. Any other questions, Winston?
Yes. So thanks for putting together the plan. I think we all acknowledge that it's a challenging time for this health board, and I think it's reflective of the challenging time that the NHS has in general. I work in another health organisation in England, and the forecasts for next year financially are pretty challenging. But just going back to Hywel Dda, I noticed that as Hugh identified earlier, that we're presenting a plan which will be a deficit plan again of 64 million. But there's sort of open risk of £6 million, I think you've indicated, so it could be a 70 million picture that we're talking about. I just wanted to pick up on the fact that you also said that the proportion of spend between hospital services and community services has shifted in the last 5 years, that we're spending more in the hospital sector than primary care. And I wondered in this plan, what steps are we making towards making sure we can invest in more community services? Because that doesn't seem obvious in terms of when I look at the numbers. I think it's written that we're going to invest in community services, dental services and pharmacy services, but there's no obvious actual money attached to it, so I'd be interested to know how that happens. But also at the same time, if we invest in one area, we have to make savings in the other, so how do we go about, or what are our thoughts about how we reduce our spending in secondary services? And most people will probably think about beds, so if we have got less beds in secondary, then we need a safety net. So that would suggest more community beds. So I just want to get some more clarity on what that's looking like as the health board.
Who wants to? You want to start here?
Chair, I'm happy to start, and I'm sure I'll bring Jill in, if I may, on community services, and Andrew to go into further detail. Yes, we do have at this point in time We don't have a gap in the identified level of savings. I think we've got a gap in the assurance of the delivery of those savings that have come through, and we need to work on that over Q1 to translate some of those opportunities that we aren't currently recognising that will deliver at this stage, de-risk those so that we can get greater assurance over Q1 that they will deliver in the year. So this isn't that there's a lack of opportunity, it's about translating those opportunities into delivery. The shift between secondary care services and community primary care, I think, is an area of continued discussion, it would be fair to say. Of course, we've seen a reduction in capacity in the community, just in terms of the number of residential and care homes that we have and nursing homes that we have, and the beds available to us to utilise. And clearly that has a knock-on impact on flow of patients through the system and therefore the impact we're seeing in secondary care. So that's the broad, I guess, assessment of how we've got to the current level of increasing the resources, relatively speaking, in secondary care. And it is relative that I'm talking here. We do recognise, though, and we've got active programmes of work in terms of the value proposition of shifting resources into the community, be that at a prevention level. So certainly some of the work that we've seen on value-based healthcare, some of the schemes that we've been working through, Heartfield is a really good example where early identification, early diagnosis is helping prevent further activity in secondary care. So there is kind of an active programme of work there, but of course there is more to do, and recognising your point that with every decision to invest at one end of the value chain, as it were, we need to disinvest somewhere else. So that's a very fair point. Jill, I don't know if you want to add anything.
Yes, thank you. And I think there's a number of questions and points that we could raise here. There is, of course, that whole issue around beds and what our community bed model needs to look like. We have got beds within community hospitals. We've got beds within people's own homes as well that we have to think about that are being supported by health and social care teams. So thinking about the overall bed model going forward is absolutely going to be critical, and we are seeing individuals with greater acuity coming out into our communities that require that care. I think there's the wider issue around the strategy for primary care and community services as well that we need to think about, and what's the actual activity that we want to shift. So there are certain pathways that we may want to develop further within our primary care systems, which would need to be resourced. And often what does happen is that we see the activity shifting, but not necessarily the resources to sustain them. We've got a number of developing models that are being supported through our clusters, through RIF funding and others that we will be expected to, at a point in time, to consider as a board in terms of how we mainstream some of those activities so that we then free up that resource for further innovation and development. So we do need a strategy around this. We can't take knee-jerk reactions, but we absolutely understand as well the acuity of individuals within our acute systems that need that support and care, and often the challenges that we don't have the resources properly developed to get people out. So I think this is an ongoing discussion around the opportunity for thinking about our beds, our urgent and emergency care model and programme, thinking about the innovative developments around pathways, and also the opportunity through our new primary care contracts that are offered through a different way of resourcing need. There's a real shift in those contracts now. Instead of community pharmacy, for example, the funding is shifting away from dispensing of items into actually meeting health need. Similarly with optometry, we're seeing now that the new contract that goes live from the 1st of April with a number of new pathways that will allow more work around glaucoma, cataracts and everything else to be supported within optometrists who've undertaken that appropriate training. So I think thinking about this in the round, Winston, is extremely important in terms of our plan and that shift. But again, it needs the resource to be able to follow that.
Thank you, Jill. Andrew, do you want to add anything?
I think Jill has done a really good job of articulating some of the work we're doing and some of the discussions that are continuing around how we generate that sort of transformational change and shift. I guess the fundamental challenge we've got is, and Hugh articulated really well earlier on, where the drivers of our cost and deficit largely sits, and it's around our acute sites and the urgent emergency care system. Is fundamentally there is a challenge for us in that our acute sites are effectively sponges for the system. They're the one bit of the system that can never close. They're the one bit of the system that can never say they're full. They're the one bit of the system that will never turn people away. They'll continue to accept and treat people that are in urgent need and emergency need of care. What we've got to do is try, through the work that Jill's describing, is give it less of that demand to absorb. And I think that's the real challenge, because without being able to scale some of that up, and it's very challenging to do that in the kind of environment we're in financially, and when we've got lots of full capacity, so it's not easy just to move resource. It's how we kind of find a way to do all of that differently in that context, and manage that demand very differently. That's the challenge. And I would say the more successful we are at that this year, the more successful our overall plan will be in terms of its total delivery.
Do you want to come back?
Just a quick follow-up really, which is in relation to so earlier we heard that there's a new structure being established across the organisation. Sorry, I think earlier we heard that there was a new structure being established across the organisation. I guess we need some assurance that that new structure is going to not only support our financial delivery, and that we need to make sure happens, but also what Jill and Andrew and Hughes talked about, which is that sort of shift of the resources into the right places. I think we need some assurance as a board, because then that will give us greater confidence that this challenging plan can be delivered as best as possible that it can be.
Yeah, no, I'll take that, and happy for anyone else to chip in as well. So I think within the principles of the revised structure, Winston, it's absolutely the case that what we're trying to do is align better some of the levers to and accountability to deliver some of this change and shift. I think the creation of a community and integrated medicine clinical care group that's responsible for community services as well as our acute medical services, I think is a big step towards achieving a different means of being able to make change. I was very struck during COVID by a conversation I had with the Mental Health Triumvirate, who commented on their ability or their surprise at some of the conversations that were going on around urgent emergency care, because within their directorate they have people responsible for inpatient and community services, and they're responsible for the whole pathway. So if they see an opportunity, they can make that happen. There's something around the new structure facilitating that. I think the other thing that it does is it rebalances in a helpful way, I think, some of our senior leadership capability and capacity, because I think we were a bit lopsided to some extent in terms of how that looked previously. And it also, I think, will start to strengthen and give a greater voice to our clinical and professional leadership across the organisation as well, which I think in this space and with the challenges we face is absolutely where we need to get to be able to tackle the kind of year, well, I was going to say the year ahead, but it's the next 2, 3, 4, 5 years. Happy to go into that into more detail outside, but I'm conscious of...
Okay, thank you. I think there will be those opportunities when you bring reports through to the various committees. So I've got Anna first, then Chantal.
Thanks, Chair. I suspect that for members of the public listening to us discuss the approval of the unapprovable, they will be struck by the sometimes bizarre machinations of NHS bureaucracy, and therefore it is really important for us to underline both our commitment to say this is not the end, this is just the beginning, and that this is only necessary today, as I understand it, because of the requirement around budget delegation from the 1st of April. That is the reason we're discussing this in this unsatisfactory manner today. I think the other thing that I would be interested to hear Phil articulate, again, sort of looking at our track record, there will be people out there who will be sceptical about whether this is any different to any of the previous number of years where we have been at March talking about a better year coming, and potentially thinking we are in Emperor's New Clothes territory here. If you were to pick out just a couple of things, Phil, that for you represent a material change in the way we are addressing our financial challenges in the coming year or 2 years or beyond, what would those couple of things be?
I won't bring Phil in yet. I'll ask him to cover that when he comes in at the end, because I want to make sure we've got all the questions. So, Chantal.
I was just wondering, because I think we've been talking about shifting resources from secondary care into the community, and that would be at the expense of disinvesting in some aspects of what we do in secondary care in order to be able to afford shifting those resources into the community. I just wondered whether, as part and parcel of the exercise, we will be doing a cost-benefit analysis of doing that in the first place. I think we need to be upfront as to whether that is affordable for us to be able to do that.
Okay. You want to?
No. I think that's a really good point, and I think that's one that we're working through in terms of understanding the plans and in terms of enhancing our community capacity. That's certainly one of the considerations we're making. I think, excuse me, there's some pretty good evidence out there that says the cost of looking after an acute patient at home versus looking after them in a hospital is about 60% of the cost. So in terms of better utilising our resources, so long as they're appropriate patients to be looked after in that way, better utilising our resources in that way should enable us to provide a better level of service, a better experience, better quality, and a more cost-effective model as well that would help bring our financial position back into line.
Thank you, Andrew. Ewan.
Thank you, Chair. I think we've heard a lot about in terms of the word community in this discussion, and I think there is a key role for our community partners within this in terms of being part of the solution, to work with us, to be part of where we can go and look in terms, as kind of Jill articulated, there's innovation in terms of what we've got being funded out currently across the 3 counties with RIF funding, and if that then can be proven to be part of a sustainable solution, it can offer cost savings in terms of the kind of wider health board bill, but also empower those communities to take ownership of what we're looking at is what we should be about prevention. So rather than the kind of reaction that we see a lot in terms of what our services are being drawn to deliver, it's about the preventative model, which we're already seeing as part of our community work within the health board. But if you go down to the kind of next layer and look at the third and voluntary sectors across our 3 counties and what those organisations are doing currently, now again it's very much kind of a reaction because they're only being funded year on year on year, and there are challenges within our communities to retain that expertise around the innovation of service delivery and service design. But I think what we've already seen within our report today is there's a clear commitment to co-production, and I think that needs to be very much kind of driven as part of the solution, but also, as other colleagues have said, about communication as well to our patients, our staff and our general public, because often our general public are the silent majority. We hear from the more vocal people within our communities who engage with us on a routine basis, but they're only the minority. I think our challenge as part of this discussion is to engage the wider population in terms of how they can be part of our solution, but using those community-based organisations with the innovation that we're seeing in terms of people being kept out of hospital, being supported to remain in their own homes with their own support networks, but allowing us to be part of that solution with our third and voluntary sector organisations. And I think it's a longer term solution rather than a knee-jerk reaction that we need to see. And I think it is within our plan, but I think perhaps we need to emphasise that in greater detail, with greater voice and with greater emphasis as well.
Yeah, that's a really good point. Okay. Helen, did you want to?
Yeah, just coming back on it, when we've done a report on healthier and happier communities, and one of the points is that they wanted more things in the community to stay healthier and happier, and that should be with the health board next week, so you can see that yourselves for the evidence that that follows up from your own statement. Yeah. Really,
that's very helpful. Thank you, Helen. Ardiana, sorry.
Thanks, Jan. We'll just comment on the last bit on the healthier and happier, and generally thank you, Ian, for making the point so clearly and articulating so well the role of prevention. I think we have to be realistic, though Andrew does cite the evidence of reduced costs when you shift from acute
a centralised provision of care to community. There are savings, but the scale of the savings, as Hugh will articulate, the scale of the savings that we would need eventually to deliver are difficult to be met by just shifting the care closer to patient. There are benefits there definitely in the preference of patients, in the access, as well as to some degree on the outcomes. Prevention, absolutely, it is very well embedded in our annual plan, has a role. There is evidence, and we're doing a little bit of work within our directorate to demonstrate some of the key preventative services and programs that we deliver and how that translates into health board savings, because the savings, the return on investment is well evidenced, but it's more of a societal and community. However, even those, our main problems are musculoskeletal, obesity, alcohol, and then even those preventative programs, even if we were to deliver at the largest scale that we could, as of today, considering the capacities that we have in the public health or prevention, would not, again, deliver the savings that would be needed for us to stay within financial envelope. Again, Hugh mentioned, for instance, the coronary heart disease, the stroke pathway. That is, those sort of services might come closer to delivering those sort of review of services. The last bit that I was going to say is, and we've got local authority representative here as well, the partnership work, particularly the example that we're using on the Healthy Weight, Healthy Wales health whole system approach on the weight, are those sort of services that could result in some of the immediate preventative, particularly in the exacerbation of the outcomes which increase hospital stay, costs, etc. Thank you.
Thank you. Thank you very much, Ardiana. Michael.
Yeah, I have a question. Probably Joe might be the one to answer this. It's just a kind of boring lawyer type question. But on the bit, taking on from what Anna said about accepting the unacceptable kind of point, where we have the bit about, we say in the actions then that we're endorsing the submission, is there a way of kind of capturing that kind of element of unease, but an unease which has been tempered though by the scrutiny and the discussion today, which I think has been good discussion and good scrutiny. So just wonder, I mean, I know some of it's captured above that, but I'm just saying isn't that the critical action point, that we're endorsing something which is is a challenge, and whether that is entirely captured in that paragraph. But so yeah.
I've got some adjustment to the recommendations actually in front of me, so we will try and encapsulate that. Did you want to come in, Hugh, before I go to?
I guess just a point to add, in addition to the recommendations, because approving a budget that is in a deficit budget is a novel or contentious action.
I was very interested by those wordings. Yes.
That's the definition we have in our standing orders. Because of that, it requires a letter from our Chief Executive as Accountable Officer to the Accountable Officer in Welsh Government, and it's certainly worth capturing some of the spirit of the conversation as part of that submission.
Yeah, we will do that. Thank you, Hugh. Phil.
Thank you, Chair. So, look, it's an really important discussion. I think, what we've really underlined is the seriousness of our situation, the fact that we are in breach of our statutory duty if we don't break even, let alone not getting to our control total. So whilst aiming for 64 million is an improvement on previous year's performance and does arrest the decline, it does not get us close to our control total, let alone our statutory duty. So I think you're right, Michael, that we just need to make sure the gravitas of that is reflected in our recommendation. And in fact, as we've heard from our finance director, there's even challenge is getting below the 70 million. So actually we do need to make sure we harness what we've identified as savings plans to get us to 70 million and other opportunities below that to get to the 64 million. We are in targeted intervention, and I think we should welcome that support from Welsh Government, because clearly we have quite a way to go to get to, from a financial perspective, to our control total or break even, but also in the kind of quality and access of services for our population. So there's a lot of work for us to do, and I think the plan does describe the first steps of that journey. Just in answer to Anna's question about the 2 or 3 things, I thought of it in, I suppose, 3 ways. I suppose the first thing I would say is that I do feel that there is a different mindset in this board, and I feel that the willingness and determination to tackle some of the challenges that we found difficult to tackle in previous years is starting to be evident, certainly in the discussions today. And I would say that we are going to have to face some really challenging discussions around how we tackle the harm, waste and variation in our system, and also much better utilisation of resources so that we do provide a much better sustainable, higher quality services for our public. I think that some of the programmes of work will take us into decisions about redesign of the way we do things in ways we've not looked at before. And I think the clinical services plan we'll discuss later will show us that. I suppose so. My second area, so the first one was about mindset and determination, which we'll need to hold ourselves account to as a board for that mindset and determination, willingness and determination. The second one was about structure. You know, I think the new operational structure, the new clinical leadership arrangements, quality governance arrangements will be really key to us making progress. And I think, you know, we're going to need to set a different level of expectation through our teams. I think we have to guard against inertia that can happen when we implement an operational structure. So that is something we're very mindful of. The other structural areas, I would say, the new performance framework, the new executive governance arrangements, and the clinical services plan work are all areas, I think, which are different compared to where we were last year. And the last thing I was going to say was that the first quarter is really important in this, because I think in previous years it's been difficult to get the kind of grip and control that we require in the first quarter, and as an executive team, we've been putting a lot of work in to being ready at the start of April to tackle the challenges that we face. So the other couple of points I'll make were that I think in the first part of the year, of next year, we also need to identify a route map to how we would get to our control total and work towards that over a 2-year period. We need to identify to board what things we think we would need to look at to get us to that control total, and we need to be guided by improving the quality of the services that we offer to our public. And I think Helen, you make a good point about a patient-facing plan. It's something we've discussed as an executive team. I know, as Leah said, Alwena and Leah looking at how we could present that to the public more clearly, because necessarily our document is quite technical and difficult sometimes for the public to identify the key points for them. So we'll look at doing that. And the last thing is we have prepared an accountable officer letter to Welsh Government on the basis that we've described today, but this decision will allow us to give budgets out to the organisation so we can operate at the start of the year.
Thank you very much, Phil. So thank you everyone for the discussions and the questions, and I would also like to thank the team for the production of the plan. There's a lot of work gone into that document, and more work clearly to produce something that's more accessible to our public, but thank you. So I would like to take us to the recommendations, which are on the bottom of page 5. I am going to make a few changes to those as we go along. So for the first one, I would like to ask that we note with significant concern that the financial plan does not deliver against our break-even duty, and recognise that this will mean that the Health Board is in breach of its statutory duty and will consequently receive a qualified regulatory opinion, and note our determination to make progress to address this. Second recommendation, to note that the approval of the deficit plan represents a novel or contentious action which will require the accountable officer communication with Welsh Government. That we also note that the plan will lead to a cash deficit for which as yet there is no coverage agreed with Welsh Government, and therefore a risk to the Health Board's cash position which will arise in month 11-12. That we also recognise that the financial plan is in excess of our control total of 44.8 million, which we as a board believe this is not acceptable, and therefore will require urgent action over year 1 to provide an acceptable route map, change the wording slightly, over the coming 2-year period back to our control total. Important approval is to approve the delegation of budgets to the Chief Executive, from the Chief Executive to budget managers across the organisation to enable the functioning of the Health Board from the 1st of April. To endorse the submission of the plan to Welsh Government in line with the NHS Wales Act, which mandates the Health Board to develop plans to improve the health of the population and improve the quality of health services and integrate health and social care planning, whilst recognising that the financial deficit of the Health Board remains unacceptable. And endorse the exploration and development of the medium-term clinical model, understanding that this will need to navigate existing constraints while striving for service sustainability and resilience, and I'd like to add, and requires engagement with our public partners and community groups. Is everyone content with those recommendations? Thank you. Thank you very much. Okay. Right. Thank you. Feels like we should take a break, but we're not. I'm going to move us straight on. So we now move on to the implementation of a Healthier Mid and West Wales strategy. And Lee, you're on again.
Again, yes. Thank you, Chair. So fairly brief update for board today, largely self-explanatory. Since the last board update, we have received further correspondence from Welsh Government, and the next steps are noted in the paper. They are in relation to agreeing and developing the options for the strategic outline case, and as a result of that, the timeline, and in addition to that, providing details of our actions taken in respect of the Nuffield report. So just in relation to those 2 points, first of all, I can update the board that in respect of the development of the SOC options, we now have a date of the 22nd of April for an in-person session with Welsh Government and Shared Services. That's referenced in the paper, but we didn't have a date at the time of the paper being written. And I can also update the board that we are still awaiting receipt of the final Nuffield report. We have followed that up a couple of times, and we have had communication. So I was hoping it would have been received in advance of today, but unfortunately it hasn't, so we are expecting it imminently. we will then, the intention is we'll then take that report into our committee and board structures and describe our response to those recommendations. Thank you, Chair.
Thank you. Questions? Maynard, then Helen.
Just a very quick one. Thanks for the update. In the organisational risks paragraph on page 3, it says the executive review with the conclusion that the risk score of 16 remains appropriate. Just wondering, because this is a public board, what does that actually mean in terms of actual actions and risks?
Yep, thank you. Happy to respond to that. So as it states in the paper, we have a risk identified, principal risk identified, which is the risk to delivering safe, sustainable, accessible services as a consequence of insufficient investment in facilities, equipment, estate, and so on. So that is at a 16 risk score, so that's a relatively high risk, which we've obviously been working within that for quite some time. What we've done in relation to that is reviewed that risk score because we obviously are facing a significant delay now to the long-term plan around the replacement of Glangwilly and Withybush in particular, but also our other sites, Prince Philip and Bronglais, are part of that programme business case, and indeed the community sites as well. So in light of that delay, there was a discussion around whether we would need to enhance that score further. The reason we deemed it not necessary to do that is we've also had some more positive developments in relation to investments in our estate over the next 1 to 3 years. So we are expecting to be in a position to make some very targeted investment in the most critical risks. So whilst it means that over the longer term, the risk is somewhat higher because of that uncertainty around the timelines, in the short and medium term, that we've alleviated some of those risks. So on balance, we chose to stick with the 16, but I think it's just underlining that we are managing with significant risks to our estate on an ongoing basis.
Thanks for the clarity.
Thank you. Helen.
Please answered it about the state funding for while waiting for a decision on the new hospital. That's fine. Thank you.
Okay, thank you. Any other questions? No? Okay, thank you. So I'm going to take us to recommendations on page 3, which I won't read out, except to just for clarity, the third recommendation, that's the Senior Responsible Officer for the programme, and that this is a change as detailed there. Are we content with those recommendations? Okay, thank you very much. So I'll move us on now to the finance report, and Hugh.
Diolch, Cadeirydd. I won't labour the report too much because I'm conscious that we've had a good discussion around our general financial position as part of next year's plan. A few key messages I do want to make sure we get across. The first one is we remain on track to deliver the deficit of £66 million, naturally recognising that there is some risk that we're managing, particularly in relation to industrial action, which of course is ongoing and will have a financial impact on us. Our cash position, I've reiterated this on a number of occasions now, is being carefully managed on a day-to-day basis. And while we've delayed some payments in getting to the end of year position, the impact of that relatively minor, and we've prioritised cash flow to naturally our staff, primary care contractors, other NHS organisations in Wales and local and small businesses. We are seeing some further slippage on savings delivery, which is a concern, especially as we need to see that step change in delivery requirements as we go into next year, but that's something that I do want to note. Capital, currently rated as green on the basis that we won't spend more than allocated by government. That said, given the late allocations that we've had in terms of capital, welcome as they are, the biggest risk is an underspend against the limit and not an overspend. I'm not hearing anything significant around a significant level of underspend, but that's something that we are managing. There is some positive news to report. So if I look at the trend of expenditure on page 4, that shows an improvement against the trend on the budget allocation. It's positive, but it reflects the degree to which expenditure plans have slipped, especially in mental health and primary care against our original budget assumptions. That then shows itself as an improving deficit trajectory on page 5. However, much of that is largely non-recurrent, so that will reset itself on the 1st of April. We've seen some really good news on primary care prescribing. That's showing itself on page 15, where we can see the contribution to the deficit having reversed, and now in the latter part of the year, that budget underspending against its budget. So some good news there that's driven by two things. One is our use of medication, and secondly, the cost per unit has reduced significantly. But to counter that, secondary care drugs is continuing its upward trajectory despite good work in moving from generics to generics and biosimilars. Oncology in particular is a real area of pressure, and about £7 million worth of our growth going into next year is a contribution from the oncology budget, driven by both inflation within the drugs budget, but also the number of patients that are being seen day to day. On pay, we've seen a small bounce back in the use of nursing agency in January and February, and that, you can see that on page 16, alongside an increase in bank usage and a substantive agency workforce being higher than ever. And page 19 shows the fill rates by departments, which is quite stark. Almost all directorates are now running at over 100% fill rates, apart from Ceredigion County and Mental Health and LD. More work is now needed to see whether that uptick that we've seen is a trend or a seasonal issue. There will be occasions when fill rates will exceed 100%, particularly because of acuity and demands that you might see to respond to individual patient needs, but I think there's more work that we need to do to get into the skin of that and understand what's really driving it. My biggest concern, though, is medical locum. We're now seeing that at around the £3 million a month level in terms of a use of medical locum. Clearly a key part of our plan going into next year is understanding that better and then moving to address it. One of the things that we have got in place is we are about to award a contract for a medical rostering system that will give us an electronic repository and allow us to manage rosters more efficiently and effectively, and also give us the intelligence that we need to, as I say, get into the skin of that issue. So, Chair, with that, I'll open up to any discussions.
Okay. Thank you very much, Hugh. Questions?
Just hear on what you said about the medical locums and the new way of working or rostering. How much of an impact do you think that will have? Will it be what net effect? I'm not. It's just a matter of kind of, you're quite positive that it's going to change moving forward, but give me some idea.
Difficult to know what the precise numbers would be, but given our reliance on locum, any benefit will fall out from, I guess, our most expensive premium spend. So we should see a bigger benefit than if we were more reliant on substantive stuff. Yeah. So that's a positive opportunity we've got. In terms of the impact, don't know yet, because part of this is to gather intelligence on what is driving our costs, but certainly having greater visibility, greater grip and control, greater intelligence will give us an indication of what the opportunity might be. So as we roll out, I think we'll see that that opportunity become clearer, and as we start to roll out, that will give us an indication of what the scale of the opportunity might be then as we continue with that process. We need to get into it, I think, first.
Winston.
Yeah, thank you, Hugh, for presenting the financial report. I'm just referring really to the last Finance Committee SRC that we had, and we indicated, or we noted, that the financial position of a 6 million deficit was an improvement of 6 million before, but we also noted that it was seen to be due to some external factors such as prescribing costs, reduction in energy, and a reduction in the risk share from Welsh Health Specialist Services. But in addition to that, we saw some green shoots in relation to review of nurse and healthcare support worker agency and usage, that the nurse stabilisation programme and increase indicated a reduction in the extent to which we're using agency. I just wondered, do you think that that momentum can continue? Because you've indicated that there is some risk to the year-end position, which, I mean, at this stage, it's the 29th of March, 2 days to the year-end. We're probably there or thereabouts now, aren't we? I just wondered whether you believe that those green shoots can continue and what it would really take for the organisation to really continue that grip and control, which is what we're looking for.
Yeah, thank you. There are probably a few areas just to pick up there. So if I start off with the positive work that's been done on nurse agency, that is going to continue. The international nurse recruitment work is continuing, so that will increase the supply that we've got of nurses into our system and support a reduction in our reliance on agency. I also anticipate that that will perhaps encourage some of those who are working on agency contracts to think about substantive roles within the health board. So that's a very positive, and that work will continue going into next year. Certainly it had an impact in Carmarthenshire. We will see that impact increasingly in Pembrokeshire and then Ceredigion as we work through. So that's positive. We're also seeing lots of opportunity being realised within medicines management. Our use and transition from branded medication to generic and biosimilar medication, I think, is having a real impact there, and some good work being done through the medicines management team. So some real positivity there that I'd encourage seeing continue into next year. There is a lot of work that we need to now do on medical agency. That's the area of opportunity that I think there's far more that we can get at, and I'm sure Lisa will have something that she can add in terms of the work that we're doing on some of our high cost locum members of staff and how we are addressing that. But fundamentally our position is being pressured by our use of beds and flow of patients through the system, and I think that's a real driver of cost that we're seeing, and the more work we can do to prevent admissions and facilitate earlier discharge will naturally have an impact for us, and that's clearly another key element of the progress we need to see maintained into next year.
Okay.
I also just wanted to add a positive comment from the last SRC. So we did hear from the core delivery group that that the digitalisation of switchboards across the health board's 4 sites created savings of £200,000 a year. So I just want to just acknowledge that we acknowledge that you're doing all that you can towards making the savings happen. Okay, 200,000 isn't 44 million pounds, but if we keep going with schemes like that, then we can chip away at the deficit.
Okay, thank you very much. No more questions. I'll move us to the recommendations on page 3, which I won't read through. Is everyone content to accept those recommendations? Yes, thank you very much. So we'll move on now to the first report of this type, and hand over to Lisa.
Thank you. Hope you can hear me okay. So, as indicated, this is the first report that we've produced of our variable workforce, particularly agency, overtime bank and locum work. Welsh Government issued a new circular towards the end of last year with a requirement that each organisation submits their baseline data by mid-January. So we met that deadline, and what you've got in the pack today is that baseline data that we issued. We're not intending to produce this report to every meeting, but as we understand the reporting requirements from Welsh Government, this would be amended, and what we would aim to do is give you an update in terms of our progress and action plans around reducing our reliance upon variable pay. The requirement from Welsh Government was to identify 3 key leads to progress this work within the organisation. So I am the executive lead. We have a lead from our nursing services and also from our medical directorate. So 2 individuals are leading a task and finish group around variable pay, and they are looking at all areas of the health board which are linked with all of the metrics that you've got with you today. They are tracking the top individuals in terms of their usage and their cost, so we can look at the various action plans around how do we reduce that, whether that's looking for an alternative worker, whether it's a recruitment strategy, whether it is recruiting agency workers into our workplace. And what we have seen is a significant number of nurse agency staff who have now joined us as substantive employees as we've begun the overseas recruitment. So that is certainly something that we expect to see more of. We have a focus in that group of reducing the reliance by 50%, which is what was in our annual plan. We recognise that is more difficult in some areas. So the task and finish group are going service by service, ward by ward by ward, and they are categorising areas in terms of green. They now have their substantive staff in place. They no longer need to use agency. They are amber in that they have not quite got their staff in place, but they have a plan, and it is something that we can initiate within the organisation, so we are confident we will get there, and there will be a date in which we expect to see that. And then there are some service areas that have categorised as red in terms of we know we need to do some work. It's not within our gift, but we are doing everything that we can to try to resolve that issue and reduce the reliance. So based upon that, I'm then happy to take any questions that anybody has, because I'm sure there's lots of information in there which would generate lots of interest.
Thank you very much. Questions? Gareth?
Diolch, Lisa. Really, I just want some clarification about the significant variation in our rates, especially for medical staff. And are we having to pay a premium in our West Wales and Mid Wales area in certain specialities? And what is being done to measure the quality of those locums in particular? And is it a better value of care that we're receiving?
Okay, so there's a few questions there. So the first one, in terms of the cost and the premium, there is something that being in West Wales does drive in terms of agency. So certainly the numbers, if we take our medical students, for example, we have more gaps than some of the other organisations because of where we are. That will then drive a particular need for variable pay. What we have got, based in December of last year, so we have regular metrics that are produced on an all Wales basis. And in a number of those areas, we do not highlight as the top organisation in terms of the percentage of pay bill that is spent on variable workforce. So some examples of that is in our medical staff group, we are, out of 6 health boards, the third one in terms of how much we spend of our pay bill on our agency. We are the highest for nursing, and for all other groups we are either the lowest or we are at the lower end. So I'm not sure whether that then tells us actually it's not that we are higher because of where we are. So others are having to use significant variable pay as well. In terms of the quality, I would then perhaps like to look at my clinical colleagues around that, because you can answer that in a couple of different ways. So can I hand over?
Shall I take it from the nursing and midwifery perspective initially?
Sharon, can you speak?
Yeah, thank you. Yeah, I think there is that risk, and I think what we try and do is when we do the rosters, we predict in advance what temporary staffing we need to be employing, and what we try and do is ensure that there's a bit of continuity in that space, so that people are familiar with our systems and processes and our policies. What we have got is quality governance indicators that we utilise as well, incidents, complaints, concerns, and we've also got some outcome metrics as well. So we've got the Directorate Improving Together sessions as well that we can utilise to monitor that and identify if we see that the trends are going in the wrong direction. So we do that on a regular basis. So and I guess that would apply for medical staff as well, Mark. Yeah.
Okay.
So yeah, but you know, the aspiration is that we will have our own substantive staff, and that will then ensure that we can provide more assurance in that quality space.
Mark, do you want to say anything about the medical?
Yeah, just to add, obviously all locums are appointed through an appropriate process and have the appropriate training and experience and qualifications to undertake those roles when they're employed. All of our departments have appropriate governance structures, and as Sharon alluded to, we do monitor complaints and concerns, and often a number of our longer term locums, so sort of become part of the team, so we know them very well. I suppose there's the other issue about the added value that you get from a substantive employee, someone who's part of the community, may well be involved in research, innovation, audit, training, education, and often we don't get that from our locum staff. Some are engaged in that, but some aren't. So I think it is certainly not a position that we want to maintain. But to assure you and assure the board that everyone who's in a locum post is appropriate to be in that post.
Okay, thank you. And Chantal.
Yes, it struck me when I was looking at the number of hours that we're taking on, of people being on the sick, and the fact that we are not able to fill the vacancies because of the location of where the job is, as, for want of a better word.
The reasons for usage are multiple, so it could be vacancy. We have got a number of vacancies within the organisation. We try our very best to fill them. It could be sickness. We are still seeing sickness rates that are higher than they were pre-COVID, and therefore that drives it. It could be service demand, so it could be part of our plan to deliver some of our trajectories and targets that we need the additional workforce. It could be because there are a variety of other reasons within that service that we feel we need the support of a locum. So what this work has done is gone into some of the reasons where we've used it and gone back to the medical rostering system for nursing. It was very straightforward because we have a system and therefore the system tells us what it is. For medical, we don't have that, so we have to go to individuals to ask the questions. What that also does then is drive data quality, because a reason that could be given, when you then look into it, actually it wasn't quite that reason, it was just one that was selected on the day. So the answer is many different reasons for the different specialties, the different services. For the ones that we use regularly, we have the action plan that looks into the why to see then what we can do about it.
On one of the walkabouts that I've done, and I can't quite remember who else was with me on that day, we did meet some of the locum nurses, for example. And when I asked the question as to why would you want to be here as a locum, given that there are vacancies, she responded by saying that it's because it gives her a lot more control over when she works, where she works, etc. So is there something that we could do in looking at our working conditions in order to attract more people on a permanent contract rather than them coming on a locum contract?
Definitely. So part of the non-pay elements of the pay deal last year with our trade union representatives was how can we work together to reduce reliance upon agency. With our staff partnership forum, with the support of Anne, we now have a working group of our partnership forum that are looking to how we can reduce agency work. And one of the work streams of that is how can we introduce flexibility. So we enable flexibility when an agency worker requests it. When a member of staff requests it, it is difficult for a number of reasons. So actually we're looking on the basis of we will treat everything with a positive response unless we can really demonstrate why that is not possible. So we have got a partnership forum next Tuesday where our staff reps, working alongside our workforce colleagues, are presenting what their ideas are for how we can bring that alive.
Thank you.
Rodri.
Yeah, just looking at the paper, and on page 4 there, if you see decision-making frameworks for nursing, since the policy did change, regarding nursing locums, and a lot of our nurses have come on full-time contracts with us, if I'm right to think that, and also my understanding is there's more nurses on the bank list as well. So I just want that assurance that because in some situations are there locums being kind of booked on 2-3 week slots here, rather than making that kind of assurance that people are looking and following the steps, explore the possibilities, additional hours, overtime, or are they just jumping to 0.5 straight away? Have we got that assurance, or is that something that we're moving?
conversation at Co-Delivery Group or FCG to extend the opportunity for booking if we need to. So so the process that Lisa's described is monitored very closely. Yeah.
Okay, thank you. Winston.
Yeah, thank you, Chair. Thanks for the reports. I can see that it's a one of a kind in a way, and it looks back at the expenditure on, in particular, agency for the year. I was just struck by the appendix, which lists out the number of agencies and the amount spent by each agency. Two things really. The first thing was that there are some agencies where we're spending quite low amounts of money, and so I'd expect that those will be one-off things. Second thing is just the number of agencies that we're using. So I don't know whether the core delivery group are looking at it, but I'd expect that in future years we wouldn't have such a wide range of agencies. But I don't know, we might have 12 or something, because it just seems to me the span of number seemed to be something that we ought to really be looking into. And there were a couple of things in there where there was no agency recorded for £34.50, but it just goes back to my point about grip and control and whether we're really looking at these areas.
Okay.
About the numbers.
Yeah, so in terms of the number of agencies, we are part of an All Wales framework around the agencies that can operate within Wales. So that's why we have that number that are there. Having the number that we have does also help in terms of being able to get a supply of nurses when you need them, whereas if you only had two, you may not be able to get the nurses that you require. But we have got a few of those agencies that are more particularly aligned to us, and certainly in our partnership arrangement in Ceredigion, there's 2 or 3 that are particularly working with us. In terms of the areas where they have small amounts of usage and areas where you wouldn't necessarily expect to see it, again, the Task and Finish group have done a deep dive into that to identify where it is. So if we look at admin and clerical, for example, there's no agency there now. But for the variable pay, we've identified it's particularly linked with our A&E, reception and out of hours. So we're doing pieces of work with those 2 teams now around what can we do to shore up the substantive workforce to not rely upon that variable pay. And then for all other areas where there is a small amount of usage, the team will be going out to say what would the impact be if we were to reduce that or eliminate that. So they're going to do quality impact assessments and put the trajectory around how could we reduce it completely or eliminate it completely in those small areas. So we're not ignoring anything at all. It is all coming through that group.
Thank you.
Okay.
Thank you.
Okay, thank you very much. Thank you, Lisa. So, oh, sorry. Sorry. Sorry, I know. Sorry, Eleanor.
That's very welcome, diolch. It's a really helpful and useful paper, and you said it's the first time the board has seen a paper of this sort. There's so much underlying base data in there. Are you using that to maybe change the way people will work in the future, or look at ongoing vacancies that may never be filled? And I'm looking forward to seeing the strategies that follow from it, because there's a huge amount of raw data in there that you can use.
Yeah, absolutely. So again, part of the action plans that the teams are doing through that Task and Finish group, they are using this information. It's already been updated for February. So every month they are now refreshing it to see what is it telling us. Is anything new occurring? Have we seen the improvement that we thought we were going to get in the plan? And then working with our service teams, it's around how do we actually then deliver some of that plan. I think one of the things that we need to really understand as well is there ever good variable pay as opposed to bad variable pay? So if we think about some of the strategies, sounds quite bizarre, but if we think about some of the strategies that take place now, so if people want to access their pension early, there are certain rules about how much you can earn pensionable. If you work on a bank, it's non-pensionable. So actually somebody could ask for a split contract to work, 30 hours a week, and they might want to work 7.5 hours a week on a bank so they can access their pension. And I think that's something that we've really got to understand and get to grips with, so that we know what we're focusing on that is costing us more money, because 7.5 hours of non-pensionable earnings is not costing us any more than if we employed, and it's actually probably costing less because you're not paying pension contribution.
And
So
it
we
adds to that flexibility.
adds to the flexibility to keep people in work rather than then thinking if I have to access my pension I need to leave. So all of that is part of the work that we're doing with our trade union reps around how can we support our staff.
Excellent, thank you.
Thank you. Okay, thank you, Lisa. If I look at the recommendation, where we've taken that forward, and the core delivery group reports into the Strategic Resources Committee, but I also note in the paper that the People Committee can also receive reports, and I can see some of the areas you've outlined. That would be a route that would go through to the People Committee. So thank you very much. Okay, I'm going to move us on to the Improving Patient Experience report, and then we will be taking a break for lunch. So, Sharon.
So the SPAR is both the patient experience feedback report and revised Improving People and Community Charter. So if I start with the charter, if I may, this was originally produced in 2020 with the assistance of patients, carers, communities and staff. And it has been fundamental really in informing our Improving Together work and the development of our safety dashboards.
Keep going, I don't know what
Keep
it is
going.
being-
It's also informed our development programmes aimed at improving experience as well. So this charter is updated, it's there's minor changes. It's being presented for approval today. Implementation will be overseen by the Listening and Learning Committee, and it will be included in future Improving Patient Experience reports, implementation and communication plans as well. It has been co-produced with CLICE, Listening and Learning and Professional Forums, and has also been through QSEC as well. So the information in the Charter will inform and share patient experience work, but the key is for the local implementation that we need to consider and how we use it in our staff training and how it's embraced in terms of our operational governance arrangements really. So that's for the committee for board today. And then if I go straight on to the Improving Patient Experience report, which I know you will have read the slides there. This report covers the period from December 23 to January 24. I just wanted to pull out a couple of things really, if I may. One was around the feedback that we receive. We receive feedback in a number of ways through Friends and Family Tests, through our Civica system, also through the Always Patient Experience questionnaire. And other methods really. And as you can see within the report, it cites that we have 14% of patients have provided feedback via the Civica system, which seems quite low in comparison to the number of patients that we see within the health board. But when you convert that into actual numbers, 14% actually represents 5,700 patients providing feedback in that 2-month period. We benchmark, and I benchmarked, and we are the highest. We do have the highest national average of the health board. However, we are constantly exploring opportunities to increase that feedback really, so that we can feed that back into our system. And I was just reflecting on Helen's comment around how we obtain patient feedback from services that are outsourced, and I'm thinking of a development we're working on at the moment, which is linked to complaints responses and improving that. Setting up a process whereby we take it through a communication hub, which is linked to our waiting list support services. There may be an opportunity there, Helen, where we can, during that patient's journey, actually put in a process whereby we can elicit patient experience feedback as part of that. So that's an opportunity I'll take back to the team and see if we can explore that further. Just to say, in terms of our reporting developments, we are at the moment using the latest version of Civica system, and we are using it to its full potential as a health board. But we are still dependent in some instances on manual searches, which has exacerbated our ability to triangulate some of the information that we have and have more insight into some of the qualitative feedback that we're getting from our service users. But from April, we will have an upgrade to that system, which will give us an API format that will enable us to interrogate the data in a more granular level, so that we can start to put that into Power BI and then create dashboards and have a more effective way of communicating and looking at it as on a trend basis really. So I'm also told, as we're in the 21st century, that this technology will provide an opportunities for us to use artificial intelligence to interrogate some of the data that we're getting through, and then we can export that into future reports. So I'm hoping that we'll be able to bring dashboards to illustrate that trend, and we'll be able to consider some new metrics as well going forward. I know I'm happy to take any further questions.
Okay.
Yeah.
Thank you very much, Sharon. Thank you. Well, I always shudder when you talk about AI, but I know it has its positive uses, so it'll be interesting to see that going forward. Questions?
Thank you, Diolch Cadeirydd. Sharon, you've started answering the question I was going to ask already. It was about that 5,700 patients. There's a number of questions. One to recognise that is a national average and we're doing quite well, but are they a self-selecting group of people who've had, by and large, a positive experience, is one of my questions. Because of that 5,700, about just under 100 will have been really, really happy with it. So you've talked a bit about what more and how we could do that, and I'd be really interested to follow that going through and see it coming back to board. The other part of that is, what do we do with the slightly less than positive feedback in that? I know there's not many, but they could be quite key in that space. And interested from you and Helen and Clive really, but how do we get to more people who may be less satisfied, not just the positive ones? It's great they're all positive, but it does beg the question, what about the others?
Yeah.
Stop there.
Okay. Thank you. Probably I don't know if it's self-selecting. We've got a broad range of areas where we do obtain feedback from, but it tends to be via text message or via QR code. So maybe potentially people who are more content with the service are more inclined to provide feedback. We've got, I guess, the countermeasure there is your complaints and your concerns. Metrics that we can monitor as well to see what the trends are doing in that space.
Is that a little bit in between?
Yes, yeah. And I think the other area is within outside of our acute hospital space, but we're going into the community and primary care. And we have started doing some work with managed practices using Civica system to obtain feedback from patients who attend the GP surgery using a QR code. What we now need to do is find a solution for patients who have a telephone consultation in that space. So we've tried that, and the plan is that we will roll that out to all the other practices in primary care as well, so we can get a bit more feedback from that area as well. Yeah. And in terms of the learning from the feedback, I think, I would look at Chantal really. I mean, we do have a process. I think it's the main reason for doing this is to listen and to learn, isn't it really? And we do have the listening and learning group as well, that we take the themes from these reports into that space. I think we've got one coming up on cancer services soon, so some of the feedback that we've had in that space has again led us to think about using the communication hub to manage inquiries from patients who are waiting to go through that process. So I think there are those processes in place, but it's always about how we can improve that going forward. Yeah.
Okay. Thank you.
Helen.
Yeah, answering that question, I was just going to say the ones that are in between maybe can, if you'd like to talk about your experience in more detail, they could give the communication hub a ring, and maybe that's something that you need to look at and have some of the staff manning those phones. My other question was on the charter, which it's great. I'm not criticising the charter, it's how you are going to inform the public and the patients that it's there, and where is it going to be displayed for people to understand what they should expect when they come into hospital. And then you talk about different languages in it, that you will help people, with different languages, and how are you going to translate this document into different languages, and where is it going to be can't even say it. Where is it going to be? Thank you. And then do you send it with a letter when they first have planned surgery or something? Is that something that you are thinking about doing?
I mean, this isn't a new charter, so it's about revisiting the current arrangements and then relaunching and re-energising and making people aware of its existence. I think if we can get into that space whereby we are issuing it proactively, which is what the intention would be, then we would look to do that. Doing that digitally would be the preferred option, yeah. So I think, you know, it's an opportunity for us to refresh this and to make sure that it's available to people using our services.
Yeah, maybe in the clinics and outreach teams and in GP surgeries.
Yeah.
You know the drill, Shannon.
Thank you.
Thanks.
Thank you. Maynard.
Thank you, Chair. If you look at the table on page 27 of the report, the overall patient feedback, we see the total 5,837 recipients. Note that only 17 of those are from the community and primary care side of things, and yet that's an area where there is an awful lot of patient contact. Just wondering what we're doing to try and improve our patient feedback from that area. The second question we just thought of is those primary care patients, are they the ones from our managed services, or are they from primary care generally across the patch?
Jill wants to come in. Do you want to go? You go first. Yeah.
Thank you. I think you did answer it earlier, Sharon, in that it was from managed practices only that this survey was collating the data at the moment, with a plan to roll it forward. But I also wanted to emphasise the fact that contractually practices are also expected to undertake a national patient experience survey as a listening exercise. They have to undertake a survey of a minimum of 25 surveys for every 1,000 patients. They then have to produce a reflective report which looks at their phone access but patient experience more generally, and then to present it at the collaborative. So every practice is expected to present their report. So there may be an opportunity to gather some of that information through the collaborative process to also help inform this, but there are other means as well of engaging and understanding that patient experience. But you're right, it's a wealth of information out there.
The community side?
Yeah, we collect the community hospitals. They have access to friends and family, but I guess it's in terms of the number, in comparison to the number of acute responses we get, it probably appears quite small. Yeah.
I wasn't thinking so much as the community hospital, it's just the patients we treat in the community.
Yeah. We probably reach individuals when they have contact with the health board, because that triggers that communication. So unless we're doing consultations on specific things, we probably... Sorry, Helen.
Well, no, I think what you're trying to say is those people who are maybe see district nurses or community therapists who don't come into a hospital clinic or GP surgery, are we actually approaching those people?
Yeah. I'm not sure, sorry, I'm not certain about the community nursing aspect. Right. I think so I'll have to go back and review that process. Yeah.
Perhaps you could have a look at that, and then it could come back through to the quality committee in that report. Thank you. Helen, did you want to come back?
Just to say that we've got a year's data now, raw data, that we'll be sharing with the health board, with Sharon and Lena, on people's experiences and what people are saying within the communities on their NHS and health board, NHS and social care. So obviously I'll be sharing it anonymously so the health board can have a look at that. And there is quite a lot of data there.
That would be really helpful. Thank you. Thank you, Helen. Okay. Delith.
Diolch. I've got one query about our poor and very poor responses. And there's, whilst I'd expect certain complaints and issues arising from our A&E, our emergency departments, what is quite stark is that we've got quite a few negatives from our outpatients. Now, is this a direct result of the industrial action
and missed appointments, as it does allude to in a paragraph, that it could be potentially due to that on page 27, or is it another issue about access to outpatients, the environment, and cancellation? So I'm quite intrigued by that, because it's quite stark that we have got a significant number of poor experiences for our patients in our outpatients departments.
I noticed that, and I did have a trip down to outpatients in Glangwili to try and get a better understanding of that, and I know it's been through listening and learning group as well in terms of a deep dive. I think because outpatients is a point of contact for everybody coming into the hospital, there are concerns raised about things like car parking via that process, about waiting times via that process, not necessarily about the service that's delivered by the outpatient department. But I don't know if you want to add anything to that,
No,
Chantal.
I think generally speaking, it's the kind of infrastructure that patients are complaining about because of the long waits.
Okay. All right.
Well, I think that needs to be drawn out,
Yes.
Chair, if I may kind of respectfully say that actually that is not an issue then of care, but
No.
is an issue of environment for our patients experiencing.
Yeah, so I'm hoping that with the new version of the system, we'll be able to interrogate that and pull out the nuances and report them slightly more accurately.
Yeah, that's helpful, thank you. I mean, I think as a number of us, I'll bring you a second, Roger, this report has come on so much from those of us who see it right from its inception. And inevitably with these things, particularly as you say, new systems come along, it can be refined to give even more detail and data. So thank you for that. Roger.
I think it's a very good report. It kind of is easy to read. Only one I just kind of it has been highlighted as one point. 24 new complaints received relating to attitude and behaviour of staff. That is something that kind of obviously perhaps it is someone's perception of kind of how a member of staff has kind of spoken to a kind of a patient. But I'm just thinking, what is the process? Nip them in the bud, or kind of so whoever the line manager is, it is kind of dealt with immediately then, is it? Just because that is something I like, attitude and behaviour of staff is something that needs to be nipped in the bud.
Early resolution as quickly as possible, really, before it comes in via any formal route. And that would be the aim. However, what it also does is inform our learning and development programmes as well, so that we can pick the themes from the complaints up in those programmes and address it that way as well, so that we're acting quickly on those concerns, but also making people aware that in terms of the values of the health board and the professionalism we expect from them when they're working for us.
Okay, so thank you. Phil, you want to come in?
Yeah, only say I'm really pleased to see us spending some significant time on this report. I think we do need to increase the amount of respondents and try and get the breadth of experience. I realise that the majority, even in the small number, are rating us positive, but if my maths is right, there's at least 500 people who didn't rate us positive over just a 2-month period. That's 500 people. I know we see a lot of people, but that's a significant number from a small report. I think also looking at the report on page 21, I think it is, and maybe 23, where you can see people concerned about the environment and whether they are whether they got care when they needed it. I think you can see there's really quite low numbers at that point, and that's telling us something quite significant, even though it's a small number. And I think the comments look like it relates to our A&Es, and we have to remember that our public are not having the best experience when they're attending our A&Es at the moment, and that needs to be driving us, because they are overcrowded at the moment, and people will, it's not the experience that we are looking for, so we do have to try and improve that. And there is variability, I agree, in the comments, between departments, when you look at the slides from 27 onwards. So I think there's a lot for us to be getting into in this report, and I'm looking forward to further iterations.
Thank you. Thank you very much, Phil. So, the board's asked to receive the report, and thank you for all the input and discussions. And we're also asked to approve the revised Improving People and Community Charter. Let's do that. Okay, thank you. So, I'm going to now break for lunch. It's 1:20 by my watch, so can we be back, please, to start at 10 to 2, so 1:50. And I think we need to take our lunch outside of this room. Is that right? Yes, rather than eating here. Thank you. We're starting shortly, and are we ready? Yes? Okay, thank you. So welcome back, everyone. So we'll carry on with the rest of our quite busy agenda, and I'm going to go straight to item 4.1, which is the integrated performance report. So that's Hugh.
Diolch Cadeirydd. I'll just introduce the report, and I'm sure it will generate its own questions, and we'll come back to those questions later. But just to bring to the board's attention some positive news to start with coming out from the report. The first is the improvement in diagnostics, significantly improved our position now in radiology, endoscopy, neuro and cardiology, which is really good to see. In planned care, the trajectories have been met in all the key RTT metrics in February, and breaches over 2 years are now down to levels we've not seen since August 2021. In the hip fracture ortho-geriatrician review process within 72 hours, that target is now up to 88.3% compliance, which is the best since November 2021. And patient experience has also improved from the notable decline that we had in January. However, it is worth noting that our complaints have deteriorated and are now at our highest level, and it speaks to perhaps a delay in the complaints coming through from that dip we had in our patient experience scores. Some natural areas for focus for us in our discussions around unscheduled care. We have seen a delay and the breaches in 4 hours and 1 hour's ambulance handovers remains an issue. ED waits as well in both 4 and 12 hours. And worth noting that the latest data capture we've got has the number of delayed pathways at 212 delays across the system, representing that challenge in handovers that we've got between our systems. Therapies is a challenged position across a number of therapy specialties, and that comes out very clearly in the data. And then on cancer, we've seen, and this is from January figures, so we don't have the February data in the report for cancer. We've seen an increase in the backlog, particularly an issue in urology, which accounts for about half of the backlog. And the single cancer pathway compliance is around 49%, which is a dip from where we'd seen the improvement in December. C. diff and E. coli remain challenged against the rest of Wales in terms of our comparison, even though for C. diff there has been an improvement based on last year's figures for us. And then just to finish with mental health, for adults, we've met the targets for 1A and 1B on the measure, and therapy weights are within, but therapy weights, sorry, are well below target. And for children, we narrowly missed the target for therapy intervention starting within 28 days, and weights within 28 days are now above target weights for assessment. But neurodevelopmental weights within 26 weeks remains well below target, as we've discussed on numerous occasions. So, Chair, happy to open up to discussion.
Okay, thank you very much, Hugh. Questions? Helen.
I can see the ophthalmology isn't hitting the waiting list are rather high then, and just want to let the board know that CLAS is undertaking a piece of work in April and May, going out to clinics, onto the ward hospitals, to see the impact it's having on people's lives waiting on the waiting list. So not so much how long they've been waiting, but the impact because they have been waiting. And that's going to be a 2 months piece of work. On that, we're also looking at waiting for treatment, and again, that is the focus on the impact it's having on lives. Is there some third sector organisation that they can go to have help? And looking to see what is out there, so that the health board could maybe show them a different way to be supported by third sector, and that is starting in May. We have some researchers undertaking some work to see what is out in the community to support people that are waiting for treatment. So just to let you know that those are 2 big pieces of work that we are undertaking in the first quarter of our new financial year.
Okay, Helen, that's very helpful. Thank you very much. Any other questions? I know the report went to the SDOC committee. Oh, Anna.
Yeah, a couple of specifics, please. The first is on delayed pathways of care, and noticing that the position in Carmarthenshire is significantly worse, even when taking into account population sizes compared with our other two counties. And just be interested to hear a bit more about what's driving that in Carmarthenshire and what's being done about it. And then secondly, although we speak about this on a regular basis, we have to acknowledge that the neurodevelopmental assessment position is simply not shifting. Have we run out of anything more that we can do to improve that position, and therefore we have to be straightforward with the public about that? Or is there any hope that we can give to families who are waiting exceptionally long periods of time in often very difficult home circumstances?
Thank you, Anna. Andrew,
I can start off on both of those, and Jill may want to come in as well on the pathways of care. So if I go reverse to support, to enable that a bit easier in terms of flow. So on the neurodevelopmental, agree. That is a really, it's one of our most challenged services and performance areas, as we've said for the last 12 months. There is a significant imbalance between demand on the service and capacity to treat people as they come through. I think it was obviously an area that we were originally escalated for from an enhanced monitoring perspective with Welsh Government. In the course of the last 12 months, there has been a national review and policy document issued around neurodevelopmental services. And I know in our most recent performance meetings with Welsh Government, they're of the view that neurodevelopmental is a more strategic issue than just one the Health Board can resolve, and are wanting to do something across Wales at a national level to find a more sustainable solution to the significant challenge that Wales has in that area, but it's also replicated across the United Kingdom. I know, though, just to say that doesn't mean we're not trying to continue to improve and provide increased access. We were stuck at 14% for a while. I'm not celebrating the 2%, but I'm just emphasising the fact that it is because we're continuing to look for all opportunities to increase capacity and provide better access. But it is a significantly challenging area across Wales. So I think that's something we will need to make sure. Obviously, we will want to make sure that when that national work is in full flow, that we're sort of at the forefront of that, because we'd want to benefit from anything that's coming out of that work. On the pathways of care, I think there is a correlation between, because I'll pick up later maybe just some of the urgent emergency care performance, but there's a correlation between the deterioration in urgent emergency care performance, a link into a significant driver of that, we believe, which is an increased length of stay and an increasing number of patients in beds over 21 days, so occupying beds, and the increase, although it's relatively small over the last 2 months, the increase in pathway of care delays. I think the point you pick up is a really good one. I was talking to Michael over lunch, actually mentioned it. It's probably something we need to take into the integrated executive group space. Certainly Welsh Government in our last couple of performance meetings have also highlighted that whilst the absolute numbers might not be as high, the proportion of pathway of care delays for our population is higher than other bigger populations across Wales. And so whilst they can see and hear a positive narrative about the actions we're taking in this space across the region, then they're not seeing that correlate back to improvement in that position, or at least not since the end of last year. I think we need to recognise that a year ago we had almost a third more delays. It was closer to 300, so there has been improvement, but we have got stuck around that 200 mark. I don't know if you want to add anything, Jill.
No, I would have brought out that improvement, which doesn't take away from the challenge we face, and we know that through our scrutiny meetings, Welsh Government continue to raise the issue around healthcare delays, but also social worker allocation and assessment, and also the fact that we do say that we've got a significant number of trusted assessors, which we've discussed here before. And Andrew and I have really pushed on the outcomes in terms of trusted assessors, and we have got some numbers which we will be able to share outside of the meeting or in a future report. But what we are hearing is this whole issue around acuity and the increasing acuity, and of course the trusted assessor takes out the proportionate lower level assessment, and so therefore isn't impacting sufficiently on the numbers that we're seeing for those delays over 21 days. So I think, as Andrew and Michael have said, we need to take it back out into IAG for further work, because we're not seeing the substantial improvement. We're also seeing in our communities, as we're aware, closures of care homes and a lack of domiciliary care as well, in terms of being able to move this forward. And I think correlating back to the work that Hugh shared in terms of our investment or lack of investment in community, we've got to prioritise some of these areas going forward in terms of trying to address this. So there is an improvement, but the improvement isn't being felt sufficiently, I think, in our system at this point in time.
Okay, thank you very much. Thank you. I was just thinking on the new development side, it's quite interesting that the new minister is mental health and early years. I wonder if that has some significance about the children waiting for those assessments, and whether we might see any change coming through in terms of policy on that area. Okay, thank you. James, do you want to come in?
Thank you, Chair. So I thought it would be prudent to inform board members of some progress regards to the therapy waits of 14 weeks. Since the concern was raised at board in January this year, the work that's been undertaken is the Health Board has approached colleagues across Welsh Government Informatics and data standards in the HCW to do an assessment as to whether we are reporting in line with the expected standards, particularly for dietetics and weight management. I've had confirmed this week on behalf of the Health Board that we've set a precedent across Wales in terms of looking into this data set. There is inconsistency across Wales regards to how we report weight management and our dietetic services. In regards to the slides of 14 weeks, I can confirm that the number of patients under dietetics at this stage for 14-week breach is 1,265. However, I can confirm that only 19 of those patients need dietetic support. So it's been an unfortunate misrepresentation of the reporting, which has overinflated our apparently poor position for dietetic services. So I think that's good news in terms of understanding our data, but also to ensure that we are reporting in line with other health boards. And Welsh Government colleagues, along with the HCW, have confirmed that that will change in terms of a reporting standard from April of this year. So good news on one regard. However, it's important to acknowledge that those 1,236 patients who aren't needing dietetic support will simply not just disappear. Those are real patients and they will be moved within the system elsewhere. So I think it's important to acknowledge that we understand our data. However, we've got another issue that we need to address, which is a number of patients that do need that level 2 support for weight management. And there is a series of actions which have been undertaken between myself, Jill within primary care and community services, and Ardiana for public health, to ensure we've got that collaborative approach for those patients.
Okay, thank you. That's very helpful, Lee. Thank you.
If I may,
James,
just in terms of in the next category, Chair, audiology, we have been informed that the 818 patients from audiology will be taken out of the RTT for 14-week therapy from April onwards too. So that will be reported completely separately. So again, it's just for board members to be aware that the data that we'll see from April onwards in the new financial year, we'll see a dramatic reduction in the region of 1,425 people that need to be seen on those waiting lists. So it looks positive, however, there's a rationale behind that.
Yeah. Okay.
Thank you.
Thank you. Sorry, I didn't mean to cut you off or call you the wrong name. Apologies. Helen.
Yeah, just to say it's important that we keep those people on waiting lists constantly communicated with, because, you know, the last thing they need is to be sitting there having their first letter saying they're on a waiting list and then not hearing anything for 52, 53 weeks. So that's the continuous communication with those people that are waiting on the waiting list.
Yes, that's. We mustn't forget. Rodri.
Yeah, just, I think, James, you did a valid point there. I made one, understanding data reporting standards. Are we aware that we might not be reporting correctly on some other kind of PIs? Because James has raised those on just those two specific ones. Are there others that we're perhaps not reporting in line with other health boards? Or is it something we should look at? Because perhaps we're doing a disservice to ourselves, perhaps.
You? To you? I don't know.
I don't believe that there's a generic problem or a systemic problem that we've got. There are a couple of instances. We've known about the weight management service for quite some time now, so it's just taken us a bit of time to get clarity from that on that, and to enable us now to transact the different way of reporting. So I don't think there's anything systemic.
Thank you. I'd like to ask a question about cancer, which is way below target. So I suppose I'm looking to Andrew to just provide some information, assurance if you can, on the cancer target.
Yeah, no, certainly, Chair, and it was an area I was going to come back in at the end and comment on, because it's a significantly important service for us, and the level of performance certainly, I think, is disappointing in terms of the access that means, or the experience our patients are getting, but also, I think, is disappointing in terms of the effort and work that our teams are doing to try and improve the pathways and improve the service in this area. I think the actions they have been taking over the last few months are, when we've been reviewing those with NHS executive colleagues, there's a lot of confidence in the actions we're taking, that they're the right ones, that they are streamlining the pathways, and that we're working towards getting increasing numbers of patients diagnosed and identified as whether they have cancer or not within the first 28 days. So there are some, I'm keeping faith with the plan we've got. I think there have been some challenges though. We obviously saw the improvement in December. We had anticipated we'd continue to see an improvement through January, February and March. Looking at the January performance and the reduction, there are three particular cancer pathways that are causing us a challenge in terms of our performance. One is lower GI, so colorectal cancer, skin cancer and lung cancer. Those are the three that are significantly influencing their overall reduction in month anyway has caused us a challenge. There's a direct link in terms of that and some of the industrial action. So in terms of treatment volumes, we have treated a lower number of patients during the industrial action in January, which has meant and because we're trying to obviously prioritise the longest waiting, the patients that have been treated are would be in the category of patients that have waited over the target anyway. So just in terms of how the performance figures calculated, there's a nuance there. The key though in those areas is how we get to a point whereby we resolve the numbers of patients waiting beyond the target, so that our overall performance does improve. I think, and I'm confident that the skin will be resolved by the end of March. Colorectal is improving, and we're improving the number of patients being diagnosed within those first 28 days, but there's more to do. I think the other area that is I haven't touched on because it's slightly hidden in terms of in-month performance, because it's the same between January and December, is urology. And that's another high volume specialty whereby we've got some work to do to resolve the number of patients that are already waiting too long. And if we look at the last 12 months, 30% of all the breaches of the cancer pathway have been in neurology specialty. So that's a real area of focus. It will require us probably to prioritise some of our planned care money allocation that we've had in the plan towards resolving that, but there is a route to resolving that. It's just going to take a bit of time to put in place that additional capacity and work through that. I'm not expecting as a result of that an industrial action in February. February to be much better in terms of performance. I will because of some of those issues.
Right. Sorry, Helen. Can you speak a bit closer to the mic? Sorry.
Thanks. It's just, can you just explain to me, is the people that are waiting to go to Swansea Bay and the tertiary services there for cancer are in your waiting list here?
Yes, is the simple answer, but it would be unfair of me at the moment to suggest that is the issue that's driving our performance. We've got work to do as a health board to address our own access and waiting times before that would become the driver of the position.
So going on to that then, Andrew, are you in talks with Swansea Bay? Have you done a deep dive to see how many people are waiting for tertiary services within the Swansea Singleton area?
Yeah, the team review that on a regular basis and talk to Swansea on a regular basis around that position. At the moment, at any given time, within the number of patients that are waiting over 62 days in the single cancer pathway, there's around 70 to 80 that are awaiting treatment or a service in Swansea.
Yeah, okay.
Thank you.
Which is only about a third of the total number, I need to stress.
Yeah. I was just asking, I mean, thank you, Andrew, for that. I just was asking Joe when this was last looked at from the point of view of patient experience within Quality Committee. I don't know whether this is something is due to have a deep dive into the impact rather than the numbers, as you always do. So that's something you could have a look at with Sharon in terms of timescales in the agenda. Yeah. Thank you. Thank you, Andrew. Do you want to...
No, I was just to say, we'll just finish on that by saying that I would want to reassure the board and the population, though, that we are treating more patients than we've ever treated before. So it's not that we're treating less people than we've treated previously. It's just we're not able, because of the demand and some of the capacity issues we're working through, we've not been able to do that quick enough, or as quick as we would want to.
Yeah, how much of this is delayed, sort of unmet need from the pandemic period? Is that having an impact of people who didn't seek help in that period for the reasons we know, or just a normal, not normal, but just the sort of increased demand you would expect?
I think certainly, I wouldn't want to say that that is driving the challenge now, or a significant cause now. I know since the pandemic, certainly that kind of factor has certainly led to a more acute presentation or a more advanced stage of presentation. I'm not hearing that that's an issue specifically now, 3 years on from the end of the pandemic, if you like, or the height of it. But I'll certainly go away and have a look at that and just test that. It's not something that's been flagged to me as an issue.
No, it's okay. The reason I say this, just from visiting some of the wards at Langwilly, the sort of anecdotal that some patients were younger with more severe presentations of cancer, and I think one of our consultants is doing some work into that, to look at the reasons. So younger, particularly men coming forward with ENT cancers than they would have expected. Okay, but I'm sure that will be reported when we have more information. Okay, thank you, Andrew. Thank you for the teams for the report. Oh, sorry, Dallas.
Sorry, Chair. It's in regard, as usual, the C. diff and E. coli. We are still a higher percentage than our other health boards or neighbouring health boards. What really is the crux of the matter? Because we can't seem to stem this.
Can I take that, Chair? Yes. Okay, so with the E. coli, if we start with that one, we know that we are significantly higher than the rest of Wales and have been for many years. We've got a really high community burden for whatever reason, and we've looked at that from an epidemiological perspective on a number of occasions. We're currently exploring the link with the coastal geography, the farming population. is interesting, but also some of the comorbidities within our population as well, in terms of hepatic disease. So those are all risk factors, I think, for E. coli. We also have historically a very good sepsis screening program, and therefore we take more blood cultures potentially than. So therefore, if you seek, you will find, and I think that's a good thing to do, because from a patient safety perspective, I would rather be taking the blood cultures and finding them rather than not being aware of them. So that is a challenge, but as you will see, the burden from the community is 84% within Hywel Dda compared to the national average of 77%. So there is something different within our population. And I'll bring Ardiana in probably to contribute to that. And then with the Clostridium, the C. diff, we have seen a reduction this year, which is most of the health boards in Wales have seen an increase this year. We are currently 5th position in Wales at the moment. Again, I think the split between community and hospital acquired is 50-50 split within that alert organism. Interestingly, Welsh Government have given us some de-escalation criteria as part of the escalation framework arrangements, and the focus now is on reducing the hospital-acquired burden for C. diff, which probably gives something more tangible to aim for. And you can see the measures that we're taking within the team. I will say there has been an improvement in the Star Smart and Focus antibiotic auditing in the last couple of months, so we will keep close eye on that trend as well. But yeah, this is multifactorial. Environment is a factor. We know hand hygiene is a factor. Antimicrobial stewardship is a factor. So it's about getting those basics right. Yeah.
Okay. Well, perhaps we could take some more detail into the quality committee, and then to explore some of those factors. It's the first time the agriculture one's been mentioned, so that's interesting to hear if that's actually having an impact on our figures. Okay. Are you okay if we move that into the...
And we have discussed in the quality committee, but we can discuss further.
Yes.
I think the only point that I would add to that is that we take patients from other rural areas like Gwynedd and Powys, which also contributes to the higher rate than some of the other health boards. But there are issues with higher testing and all the geography, and we will look with local authorities at the water sources, because we have a higher number or proportion of private water sources in our batch as well.
That's really interesting, and of course water quality is very high on the agenda at the moment, but of course, yes, I hadn't thought about the supplies that are not part of the main supply. Oh, sounds like a very intriguing piece of work to explore and improve. Thank you very much for that. So thank you, everybody. Andrew, you were going to say anything else?
No, I suppose I just thought, given I was just conscious that with some of our escalation, just some of the issues Hugh raised, there was probably just a couple of other points I just wanted to cover. No, it's fine. So we've touched on urgent emergency care in the pathway of care discussion. The chief executive commented earlier on in the patient experience report section of the meeting around the experience of patients in ED, and I think we need to kind of recognise, as we have done, recognise again and apologise for the experience and delays people are seeing. The system has been under incredible pressure. We've been in a internal business continuity incident in 3 of our sites at different points over the since we last met as a board, and that has, and to a level of, I would say, to a level of pressure that is different to what we've seen before. We're trying to get under that, just in terms of numbers and the lack of capacity we've then had, and how we've had to go about managing flow to create a bit of to balance risk across the community and the sites. I think there's definitely some interesting information, as I said earlier on, in the length of stay information. There's also some interesting information in terms of what we're seeing is a significant increase in the number of frail elderly people being admitted to hospital, and so there's something for us to do, I think, just in terms of understanding that as we go forward and into next year, because that's going to be going to have to be a fundamental part of our plan for addressing some of the challenges that we've got in our plan next year on a number of fronts. And I'm conscious as well that for the last 3 months, therefore, our performance for the first time, for the first 9 months, we were always better than the same month last year, which was the aim in the plan. For the last 3 months, we've been consistently worse than our same performance last year. So that is a concern for me and a challenge, and we're obviously looking at how we what more we can do to help mitigate demand and improve flow in the context of some of the conversations we had earlier. The only other point I then wanted to flag that I don't think we've covered was just around planned care. We're obviously a couple of days off the end of March, but it's a bank holiday, so effectively we sort of, as of today, will have concluded most of our elective activity. We have made progress even since the report, since the information that's included later on in the operational update, but we'll have nobody waiting over 104 weeks for an outpatient appointment at the end of March, which was one of the indicators that Welsh Government have been monitoring everybody on in year. There will be around 3,800 patients waiting over 52 weeks for an outpatient appointment at the end of March, based on where we are at the moment. Not insignificantly impacted by, through the industrial action since Christmas, we'll have lost around 2,500 outpatient appointments. So they wouldn't all have been new appointments, and they wouldn't all have been sort of longer waiting appointments, but it gives you a sense of the capacity we've lost. In terms of then treatment for 104 weeks, we will only have, the Welsh Government have been particularly concerned about patients waiting over 4 years and 3 years. We've managed to improve on where we thought was going to be our best case position on both of those numbers as we've come in towards the end of the year. So we'll have 46 patients waiting over 4 years at the end of March. 5 of those are in vascular awaiting treatment in Swansea, and 41 of those are orthopaedic patients. But we're working on a plan to clear those by probably the middle of May, end of May. And then we've got 173 patients waiting over 3 years in orthopaedics and 9 patients waiting over 3 years in vascular. So again, they're waiting for Swansea. So that's that gives us, we know in no other specialty anybody will be waiting over 3 years, and we'll have 1,500 patients waiting over 104 weeks then at the end of March. Within our plan and within the plan we've set, we get quite close to clearing 104 weeks through next March with the money that we initially identified and agreed this morning. There is a capacity gap at the moment in orthopaedics, but that is closing all the time at the moment with the work we're doing. Looking forward to next year. So
that's really helpful, Andrew. Thank you for drawing attention to that. And I think, I don't think any of us underestimate the amount of work that's gone into doing that. I know you've set some very challenging targets on improving performance and productivity, so that will be monitored through the year. But thank you to all the teams for doing what they're doing. And I don't think any of us are content with the long waits at all. But I think we can see that work is going on to try and reduce those long waits. And I think the work with Swansea needs to show that that's having an impact on those very long waits. Okay, thank you very much. Okay, so if we've noted that report, so I'll move us on to the operational update. Andrew, I'll come to you. I think a lot of it we've probably gone through.
Yeah, I only had 2 or 3 comments I was going to draw the board's attention to, because we've discussed a number of the issues through the course of the meeting. I'll hand over to Jill and see if there's anything she wants to add. I think, so first comment I was going to make is I'm conscious that this is a board report that we commenced during COVID. It was at a point in time when we were as much giving a reflection of the operational impact of the system as a result of the pandemic and what we were doing to try and recover services from that, and some of the management of what was the essential services framework at that time. I'm aware that we've moved on a number of years, or 2 or 3 years now, and with some of the changes, it may be I'd welcome a conversation with the board and colleagues at the right point, or offline around how we might evolve or think about what the content of this report needs to be going forward, given there was a bit of overlap with other reports that we get routinely. The only other, so that was just as an introduction. The other two things I just wanted to pick up. The report talks about the Perfect Month that we've been running around theatre efficiency in orthopaedics over the last 3 weeks. Well, the previous 3 weeks, not this week because of the industrial action. And there's some really encouraging feedback from that for us from those 3 weeks. We've got back to levels of activity in orthopaedics that we last saw in 2019, 2020 prior to the pandemic. So at times 2-3 times the number of patients being treated than we've seen, and we've been running at double the number of theatre sessions in orthopaedics. And there's a lot of rich learning coming out of the work and the focused effort that the team have put into running that. There was a hell of a lot of planning going into that to make that happen and work. But having been to some of the sites where that's been running, it's been really pleasing to see the buzz amongst the elective teams around them having, almost too busy to talk to me because they're going to theatre, whereas before they had enough time. So it's been pleasing from that perspective. There is learning, I think, if I'm being really pedantic, which you might expect me to be, is whilst we've got the level of lists up and we're doing more operating sessions, the utilisation still gives us a lot of opportunity to go at. So there's productivity gains still there from those additional lists, which again you'd probably expect me to say. So, but encouraging, and I know there's a formal feedback meeting for me next week and with the NHS executive, and I know from the input that they've had into it, they've been impressed with how that's gone for the last 3 weeks. Yes. The final point I just wanted to make then and draw the board's attention to, because we referenced it last time, but it was just by way of an update, and some of this, some of the response to this has been discussed through committee, I know, but we've obviously had the review of Section 136 services. Last year it was something Mandy, as the outgoing Executive Director of Nursing, commissioned prior to finishing. The service, I know, have presented the findings of that, and we're going away to Quality and Safety Committee, I think it was, and have gone away to work through what the options are now. They've been working with partners and stakeholders across the region to develop those options, and we're getting to a point whereby we're just bringing those back and working through what the next steps and timings are. I know they've been talking to Helen and her team in Plyce, and we know, and in relation to that, there will be a period of consultation around those options once we're content as an executive team that we're comfortable with what's being suggested. So it was just a flag that process has moved on, and the intention is that if all of that were to plan, then probably July board we'd be looking to bring something back that's signifying what the preferred option might be. That time might be subject to change depending on those conversations over the next 2 or 3 weeks.
Okay, thank you very much. Jill, do you want to add anything?
I think we've covered a number of issues.
Okay,
so
thank you very much.
Thank you.
Thank you. Questions? Maynard?
Yeah, one question, well, two questions. First one is, in the table on top of page 4, trying to understand why the numbers weighting over 4 years in urology have gone up, because we've invested money in that service. Second line down, there was zero, without investment it's 0 for 4 years, with the investment it's 12. I'm misreading it.
I can't. Sorry, so that's because through the course of the year there's been a challenge, I think, from where we started the year. But you'll note from the report, from the update I've just provided, we've cleared those long waiting patients anyway.
Great. So, and the other comment was on the primary care dashboard that's been developed. Great to see that the work done in Hywel Dda is being looked at from the perspective of rolling out all Wales. And and it's been developed with our managed providers. Just wondering, are we doing anything to roll that dashboard out to help our contractor services?
Yeah, that's the intention now of the All Wales work, and we'll be the pathfinder in that. There's certain permissions that have to be requested, and obviously working with Hugh and Anthony and team about a data warehouse in terms of how that data is maintained and managed. So certainly it's work that we expect to do across all of our practices, and we would look forward to bring into the relevant committee some of the information in due course.
Okay. Can I just ask Andrew, if on page 19 you talk about, you've mentioned the industrial action, and obviously there's, we're in the middle of coming to the end of it, so when will you have a clear idea of the impact of the junior doctors action that's taking place now?
We collect it more or less in real time, so sort of early next week I'd be able to give a view as to, we'd have an idea of, well, we know already the number of doctors that should have been, that were rostered to work and are striking or are in work, but also in terms of capacity we'll be able to give a very early view next week as to what the actual impact that has been.
And do we know the outcome yet of the other BMA ballot for specialists, associate specialists, consultants?
Yeah, that's come through. In fact, I'm only commenting, so I know something's landed today around definitions of what Christmas Day cover looks like for the period of planned strike action in April, which includes both consultants and SAS doctors.
Okay, so we'll need to keep an eye on that, will be reported through. Okay, thank you. Lee?
Can I just make a very minor point? I think Andrew referenced consultation in relation to section 136.
Engagement.
Sorry, it just point of correction, it should have been engagement.
Yeah. Thank you very much. There was a raise at the eyebrows then, Lee, you missed it. Okay, if there's no more questions, we're asked to receive the update report and note the intention to engage with the public on the service models, section 136. Thank you very much. So we'll move on now to the clinical services plan. Phil, are you starting on this, or do you want to straight over to Lee?
Well,
Lee?
only to say that we've already referenced just how important this piece of work is going to be for us over the next year, but other than that, I think I'll hand over to Lee.
Yeah.
Okay.
Thank you, Chair, and if I could just welcome Ben Rogers as well to the board. He's one of the principal programme managers within the Transformation Programme Office and has been with other members of the team doing a lot of work on this issues paper and the clinical services plan up to this point. So as Phil has recognised, this is a significant piece of work for us, important in a number of ways. I think everyone appreciates that we've got some significant service fragilities, and that's come up in a number of items through the conversations today, the annual plan, the temporary workforce utilisation, paper and Andrew's updates on operational performance. It also comes through in the quality and staffing and financial implications of our current models of care. So I think we all appreciate that our rurality, the workforce deficits, the condition of our state present some really quite fundamental challenges to us as an organisation. So in response to these concerns, we've obviously established a clinical services plan, which is looking at how we provide services over the medium term in light of these very real constraints. This report represents the conclusion of phase 1 of this programme of work and details the key issues identified for each service. And the purpose of this is to allow us to be clear on our starting point for each of those services and what factors we need to consider in developing and designing potential options, which we will work through as part of phase 2 of the programme. So you'll see that the issues paper is a substantial document. Now that reflects the fact that we are looking at 10 services here simultaneously, so that's a significant undertaking, as you appreciate. And you'll see that we've looked at those 10 services in 10 different ways. So we've looked at aspects relating to clinical effectiveness, incidents and complaints, patient experience, and early engagement with staff and service users alike, amongst a number of other ways of looking at it. So the SPAR sets that out in detail in a summary from the key service areas. It also sets out the methodology we are intending to work to for phase 2. So today we are recommending to board that all services are taken into that phase 2. That is a question for us, but I think our recommendation would be that we should take them all into that phase. We also set out the process we intend to run through to develop those options, and you can see there's a series of workshops and so on. As we mentioned before in other meetings, we have set a very challenging timetable with the intention of completing this phase in advance of the September board meeting, which is very quick, and I think that will present some challenges for us in obviously having capacity to support that, but also this is a process as much as anything, and people's thinking will need to evolve around it. So there is that point for board members to be aware of. The paper also identifies that the development of primary community strategy will need to follow a similar but slightly different methodology, recognising that the topic is much broader and the output is likely to be a little different, and it will be a strategic response to the risks in relation to workforce and state, but also start to describe our aspirations to deliver more services in our communities. I would like to clarify on that point that we are in the process of establishing a revised governance arrangements within the Health Board at the moment, where a number of programmes will come together under 3 executive-led reporting groups. So in relation to that, one of those groups will be responsible for overseeing the strategic programmes to include the Clinical Services Plan, the Primary Community Strategy, plus other strategic plans such as digital and population health and so on. So the intention there is all of these plans will then come together in one place through that forum. So this is clearly a very important programme for us, as we've mentioned, and there has been a substantial amount of work completed to date, which I think you can see reflected in the document presented today. And there's obviously a great deal more planned over the coming 6 months to enable us as a board to make informed decisions on the future models for that medium term. So just to conclude, Chair, I'd like like to thank all the teams for their input into this up to this point, in particular the work of the Transformation Programme Office within my directorate and all the operational and clinical teams that have been on the working groups to support us in this process up to this point. So at that point I'll finish.
Okay, thank
Chair,
you.
take questions.
Questions? Right, Eleanor.
Thank you very much, Lee. It's just to ensure that there is staff representation in all elements of the clinical service plan that's going to be implemented. And I have been made aware that they're taking us to Staff Partnership Forum on Tuesday to make sure that the unions are all informed at the same time, even though it's been out, they haven't been looking into it deep enough. So.
Yeah, so yes is the answer, and reassurance around that. And as you know, we have been taking it to Staff Partnership Forum regular intervals, and there've been various other conversations and meetings around that. And we have got, well, we've got certainly got trade union representation then in the options development, but the majority of the people involved in the options development will obviously be staff. I don't know if Ben, if you want to add anything to that in terms of the process.
In terms of the options development group, I'm not sure if that is. Can you hear me? Okay.
Yeah.
There's around 71 plus staff who are attending the options development group process. A significant number of those are clinicians, nursing and operational leads, and then support services as well. In addition to the options development group, there's also something called a group 2, which is our key attendees around service users and other groups that need to be engaged in the process, and they'll be actively engaged in the whole process from the deliberative session taking place in April through the check and challenge process in the midpoint of this next phase of the programme, and also the shortlist scoring. So there is definitely a co-design sort of process taking place in the programme going forward. With the check and challenge, the staff user group will be the same cohort being invited as for the early targeted staff engagement, which is circa 700 plus have been invited to that, including service users. And in addition to that, the expressions of interest for this next stage of the programme, we had over 100 service users come back with an expression of interest, Of that, there's a shortlist that are going forward to the next option development process. Around 8 or 9 have confirmed that they can actually attend and will be engaged in the process, representing whole different areas of the health board as well, which is excellent.
Okay, I think I'm going to bring Lisa in because I think we need to just clarify the issue about the trade union involvement, which is slightly different from staff.
Yeah. So just to give some assurance, really, our partnership forum, we have 2 sections, an operational section and a strategic section where we then focus on all of these elements. What we're doing from Tuesday next week is we're switching the agenda, so we do all the strategic things first. Because what tends to happen is we get caught up in lots of the operational issues and run out of time for a proper conversation. So we're making that change from next week to ensure we have full engagement.
Great, thank you. Thank you both. Thank you, Ben. Eleanor.
Thank you, and thank you for the paper. The importance of it all comes across really clearly. The one I wanted to ask you about, Lee, is the approach around primary care and clinical services. Clearly, from the paper, understanding it's different. What sort of timelines are you expecting to put around this? Because I can't see a time scale in it. I understand you said it's going to be shared in the future, but would welcome a bit of clarity around that. Please.
Were you about to jump in, Phil?
I don't know. Are you jumping in?
Look, maybe I'll help with this. Because I think with this piece of work, it's you know, when we developed our strategy back in November 2018, we recognised that this was an area of particular focus. We've already talked earlier about the fact that we found it traditionally difficult to invest in community and primary care services as opposed to hospital services, which are more thirsty for resource. And I suppose what the work that we've done over the last 6 to 9 months has identified, I think, that was reaffirmed the complexity of the work and the multifaceted nature of the work, and I think probably we need to take stock at this stage, because I think when I look at the timelines that we've given around, I think September or November in the past, I think we need a really clear plan stretching back from a date, so that we can have confidence that that is a date that we can stick to. At the moment, I don't think we have that clear plan in place. So I'm meeting with both Lee and Jill early in the new year, and we'll need to come back to board with a clearer timescale for you.
Thank you. And by new year we mean new
financial
year,
yeah.
not waiting till
New
next
financial,
January.
new financial
Yeah.
year, the one that's starting in a couple of days' time.
Yeah. Okay, thank you. I knew, thought it best to
Yeah.
just clarify. Helen.
Again, obviously there is communication now with all staff within the hospitals, and that drips out into the communities, as we know. So it's about trying to engage with the communities, telling them that you're looking at this clinical strategy. And then my next question is that you're saying it's interim, hopefully until we have, the health board has the money for a new hospital. So for the interim period you're looking at this. My question is, what if you don't have the money? So will you have to look at the clinical strategy in 8 years' time again or not?
Yeah, I'm happy to respond to that. So I don't think we use the word interim. I think we describe the word medium term. So I guess this is about us recognising that over the next 3 to 5 years, fragilities that we've got in the services we've identified have either already surfaced and become a significant concern, or are likely to, because we've already got issues around that. So this is about us saying, irrespective of what the long-term plan might be, we need to take action now to come to informed decisions about how to deliver those services over the next 3 to 5 year period. So to that extent, it is separate to what the long-term plan might be, and obviously however long it takes to come to a different long-term configuration, and the estates resolve some of the estate issues we've got. That's almost a parallel piece of work, really. So I probably I'd hesitate to talk about this as an interim or temporary in some way. These are the plans that we need to work with going forward, and and design them in that way.
Okay, thank you. Any other questions? Okay. Yeah, thank you. It is a very long document, but actually it's a really good document. So, Ben, I'm looking to you because I keep looking at Lee, but I guess you've probably had a lot to do with throwing it together. No offence, Lee. So thank you for doing that, because it's a really good read. When it is long, but there's a lot of information there, and it is very good. And I think there is something, as we had the conversation earlier, about how you can get sort of bite-sized chunks from that could be communicated. And I know Alwena couldn't be here today, but I know she's listening, so she'll be cursing me for adding something else about how we can work to have a document, or parts of a document that are accessible to the public. But thank you for all the work you've done on that very much. Recommendations are on page 12. So we're asked to note it, which we have, and agree the 9 services, so we're content to do that. Agree to the primary care being a separate piece of work, but I would ask if we could have a date brought back to the next board meeting when you've had your meeting, so the board is very clear and they can expect to see progress against that. And then take assurance on the methodology and note the risks. We're content to do that? Okay, thank you, and thank you very much again, Ben, for that. So if I move us on to board assurance framework, Phil, or do you want Joe to take this?
So I think Joe's going to take this for me. Yeah, thank you, Chair. So I'm conscious of time, so I'm not going to go through the detail. The report's there for members to read for yourselves. But just to call out that the outcome measures and the principal risks have both been reviewed by the exec team since the November board when this was last presented. And in terms of the planning objectives, we've already had a conversation this morning with those that are behind, and obviously the paper states those that are complete as well. So again, it's just any questions, Chair.
Okay, thank you very much. Joe, any questions, Maynard?
A few things. In the document on page 3, it talks about the strategic objective 4, and we've now put some it says timely data sources have been selected and agreed. One, I have concerns when you look further on about some of the dates associated with that information, some going back to 2022 and some going back to 2019. So want to understand a little bit about the way those are calculated, such as how is the mental health score calculated, and why does the percentage of people agreeing they belong to the area is important in terms of objective 4, and is there anything we can do about the timeliness of the data associated with some of the measures?
Yeah, I'd have to defer to our Director of Finance, because the measures are pulled through Hugh's team. I don't know if you can help me with that, Hugh.
Alwena wants to come in as well, so do you want to?
I'm happy to jump in, Alwena, if you want to.
Add if needed.
There we go. So the data is publicly available data, and one of the challenges I think we've got to the board assurance framework is that the data that we are able to get, because it's crude, relatively speaking, it's going to be based on national work, it's going to be based on national surveys, is inevitably going to be quite delayed in coming to us, notwithstanding the points that you made. So we're just limited by the frequency with which that data is available to us. And I think there's perhaps something for us to reflect on, whether this is appropriate to allow us to keep oversight as a board, and whether there's something else we need to do. That's a conversation we did start in our last executive team discussion on it.
Alwena, which one too?
Well, you mentioned specifically, Maynard, the mental health and well-being, and yes, correct, 2018-19, it's based on the National Survey for Wales, which there was a later survey, but the regional, i.e. However, data is only from the 1819, so we completely rely on the national data sources and the time lag. For instance, some of the mortality data, it's the time lag that is available. For the public health BAF, we are definitely reviewing because of that reason, because I don't feel that some of the indicators in the BAF give the board ability to have an assurance on the delivery of our health and well-being, because there is such a long time lag on the data that we collect. So we'll be reviewing that. Thank you.
There's also been some work done as part of the Regional Partnership Board to look at this area, which is our population needs assessment, and Arch have done some additional work on this. So is that something you're also drawing on?
Arch has undertaken a health needs assessment, a comprehensive health needs assessment, which is just a snapshot of the needs or the burden of ill health in our population.
Okay, thank you. Bill, do you want to come in?
Only just a general point that, you know, there's a number of things we have re-looked at as we start the new year. We've reformatted our planning objectives, so we've got a much shorter number of them, so I think that's sort of clearer, hopefully for the board. One thing we haven't done is changed our strategic objectives or suggested that we go through a process around that. The reasoning for that is that there's quite a lot of other priorities for us, I think, right at the start of the year. And of course we will have a new chair, but it's just to say that, of course, by agreeing to this approach, we are continuing with the same 6 strategic objectives for the moment.
Okay, thank you very much for that. So we're content to sort assurance on this? Okay, thank you. So we move on to 4.5, which is the application close the Larne branch surgery. Jill, do you just want to give the highlights?
A number of papers here for the board to consider. I'm not going to go through all of the detail, but it is important that you understand the recommendation that I'm bringing forward for your consideration today. We received the application from Coach and Horses Surgery in September 2023 to request they close their branch surgery in Larne, which is 4 miles approximately from their main branch surgery. We know from the information that we have got that about 1/3 of the population live nearer that Larne branch than to the main branch of the practice. But what the practice were concerned about was their workforce. They operate a predominantly medical model and they wanted to consolidate that on their main site. There were issues in terms of the maintenance of the building and being able to financially sustain that building in its current form. And also they felt that they had some pressures that would lead to unsustainability in terms of their services overall. So we've undertaken, as you can see from the paper, the appropriate engagement process with members of the practice, patient population. And I do want to express my thanks actually to the patient population for the way that they have engaged. I also want to thank LICE for, although you are a separate body, for working alongside of us, and you have provided your response to us today, and our communication engagement team who have helped support this also. I also want to say thank you to the practice, because what we have had to do is to extend the process to allow members of the practice population to engage appropriately with this. So a second engagement event was held in February, and you can see that on both occasions over 100 individuals did attend those face-to-face engagement opportunities, and we heard a lot of concern around travel, ability to access appointments on the main site, the importance of having that local service in the community, which post-COVID provides services around phlebotomy, chronic conditions management clinics, and there's a leg ulcer clinic there also. But we do know that since COVID, there have been no GP appointments based at that facility. The other thing that we know was provided to the board in December was a petition signed by over 1,000 individuals, which we also need to take note of in terms of the overall responses that we've received. There have also been several opportunities and mechanisms for individuals to provide their feedback, such as questionnaires, etc., which were collated to provide information for the branch practice panel, which operated in February. And you'll see from the feedback from that panel that there was a split position reached by the branch practice panel. And the role of that panel was to provide a recommendation to the primary care contract review group, which would review that information and bring the recommendation to the board today, but has the opportunity to consider afresh the issues that were raised. I think one of the really important points, though, which was raised at the end of the branch panel and is actually recorded in the minutes, was that the key point from the chair that in arriving at the decision that they came to support the application at that time of closure, the important point was that there was still this importance of having a presence within that community, and to consider how that could be provided if the building wasn't feasible to be able to operate. I think that was really important in terms of our consideration in the primary care contract review group, because the primary care contract review group doesn't have a vote. It had to consider all of the issues, and we had to undertake a fresh learning from the committee. We had to consider an equality impact assessment, which demonstrated that those who would be most affected by any change would be those who are older and those who are disabled. We had to look at the petition. We had to understand the views from the practice in terms of the position that they put forward. But again, there were mixed views in terms of the outcome of that position. But I think what we were not able to assure ourselves in that committee was that without that building at this point, that a service could continue. And what the practice weren't able to provide in terms of the evidence that they brought to the branch panel was sufficient information as to how they would be able to re-provide that capacity on their main sites at this point in time, and also maintain some sort of a presence within the Llan area. So it was really on consideration of all of those issues that we would be recommending at this point in time that the branch application is declined, on the basis that there is a third of their population who lives closer to that Llan site, that there are important services that are being provided at this point in time through phlebotomy, chronic conditions management clinics, etc. That the equality impact assessment demonstrates that those most affected would be the older age group and those who are disabled. And I do need to reflect a report that has just been issued actually from the Older Persons Commissioner called Access Denied, which has come out in the last week, which again raises this issue of older populations in particular being able to access services in primary care. But it wasn't something we considered just at that point, but it's an important point to note. And I think what we want to recommend is that whilst we would recommend that the application is declined, we wouldn't be expecting the practice to necessarily support GP appointments. Those would continue to be consolidated on their main site. But we would work with them in terms of the options that can be considered in the community, including some of the cluster services that are provided, and therefore you could optimise those services further in Llan. But also there is still the option for the practice perhaps to consider providing that service out of a different facility if that was possible going forward. So that was the recommendation, Chair, which we wanted to bring to you today. And in addition, a recommendation around streamlining the process going forward. We have a more streamlined process for a vacant practice panel process than we do for the branch surgery process. And it's something that, working with the governance team, we'd like to raise going forward. But the recommendation that we're bringing to you today, after really robust consideration, feedback from members of the public, the independent report from PLICE also, which supports the fact that the branch surgery should be declined, and the other factors that I've raised for you today, notwithstanding we will continue to work with the practice to look at the future. That's the recommendation that we would be bringing to you today, Chair.
Okay, thank you very much, Jill. Questions? Helen?
Yeah, just to agree with Jill, with everything that Jill has said. There is a strong passion for the health services within Llan, and the community want to work with the Coach and Horses to deliver the services within the community. It's not that they want theirs and the community. They want to work with the practice and maybe develop a patient participation group and try. And what we heard is that the community want to help to maintain that building, so they could have their services delivered from there. So the community wants to work with the practice. This is the first branch surgery application I've had where a third of its patients did go to Larne for their GP appointments, blood appointments, and their GNMC services. So it's a large proportion of those patients living in Larne, Pendine area, and it has got an increase of the older population there because people are coming into Larne to retire. And as I say, it's not as if the community want to work with the GP surgery to bring in some health services being delivered from Larne.
Yeah. Okay, thank you, Helen. Any questions? No? Michael. Oh, sorry, Michael. Sorry, Michael.
Thanks. Yeah, I was just interested in the point of you're saying, Jill, that there's a kind of to flesh out the kind of vision going forward. Then, because what you're saying, what we're having here is there's clearly a challenge for the sustainability of the GP practice, and that's a common theme, particularly in rural areas. But what we're saying is, in a way, we'd like to see a bit of a kind of a route map forward which can make it work despite those concerns which the practice have. So this is a kind of interesting model that's developing here. And how fleshed out is what the services would be, or is this still at the drawing board? Because what might be able to be provided might be brilliant, or it might not still meet the needs of the community, or the community might think it doesn't meet their needs. So how fleshed out is what the new model might look like, or is it something which is being developed as we speak?
So firstly, in terms of sustainability, you know that from a primary care perspective, sustainability of general medical services is absolutely a priority from my perspective. But one thing perhaps I didn't emphasise sufficiently is that the practice scores very low on that risk of unsustainability in comparison with other practices across Hywel Dda. So we did take that factor into account. But what we have seen in another branch surgery some years ago now, which had a much smaller population, and the board did decline that application, was that they have been able to actually make their branch surgery flourish to a degree with a range of community-based services that can be provided. So there's more work to do with the practice in terms of looking at how we can add to phlebotomy, chronic conditions management clinics, leg ulcer clinics, etc., out of that building. There are things that are services that are funded through cluster funding that are based in community, some mental health groups and other things that could make use perhaps of those facilities as well. So that would be needing to be described further in terms of that discussion, but it would be the discussion that we would have with the practice. It's things that we have discussed with them previously, but not in any depth yet at this stage, because clearly we didn't want to presume the outcome of any discussion today. But I think for us, this leads into our whole conversation around primary and community services and our strategy going forward, because there are many small communities, some smaller than this, but we have to think about transport and, you know, issues that we were hearing when we've engaged around land consultation things as well. But even though this is only 4 miles away, the bus service is quite difficult to manage when you may or may not have an appointment that you might travel to and find that there are no appointments left, and so you go back home on the bus. Some individuals were talking about a 5-hour round trip, or a taxi service that costs £15 each way, so £30 a time to get to the main branch is quite difficult. And if we can use the capacity to provide other things which don't need to be provided on a main site, and do that more effectively in partnership with the practice and the community, then we would want to describe that. And I think this is a conversation we're going to hear many times as we go out to talk further to our communities in terms of how we use technology, new opportunities, different teams and things to provide services going forward, and also how our communities work with us to develop that resilient model, bottom up, the social model for health that we've talked about, and how we also work with social care and our third sector partners in terms of the models going forward. But I digress slightly from the main point.
Okay, thank you, Jill. I think it's, you've said what I was going to comment on, which is it does fit exactly into the strategy going forward for community and primary care, and maybe not only seeing it as a branch surgery, but actually a community asset, which happens to be owned by one of the partners, but could potentially offer a lot more than what they've been doing there. Okay, thank you. So, if there's no more questions, we have got the recommendations here. So we are asked to approve that the branch surgery closure application be declined. We content as a board to do that? Yes, with the caveats that are down there. Then the final one is there to request a review of the primary care decision-making arrangements. I think we should definitely take that forward, and I can ask that that's brought back to the board in July. And if I can also add that in the interim, if there's a need to use this again, there can be discussions with our corporate governance team as to what's the best way forward with it, in the absence of having the finalised revised process. Is that okay? I'd also like to thank members of the public who've come today, and thank you for being so... It's probably the first time I've had an applause, so thank you for that. Thank you for coming and your patience sitting through the rest of the agenda. Thank you very much.
Thank you for enlightening us. Yeah.
Okay, good to see you. Thank you for coming.
As a member of the public, take my hat off to you, because you've got a hard job.
It's very kind of you.
I can assure you the community are behind this. And,
Brilliant. Well, thank you very much. Thank you. Bye-bye. Thank you. Oh, bless. Oh. Alan, are you going as well from this bit? Thank you. Again, lovely to see you. Thank you. Gosh, I think it is the first time I've had a round of applause. So thank you. Thank you, Phil, for that vote of confidence. Right. Okay, shall I move us on to what's actually quite a good piece of news on the primary care front? Jill, you're on again.
Yes, thank you. And this is a Cross Hands and Tumble GP contract award. You'll recall that we had an extraordinary board in December following a vacant practice panel for the Cross Hands and Tumble surgery contract, and we brought to you at that point that we would go out for procurement, which was the favoured option of the vacant practice panel, to try for tendering for an alternative provider of general medical services or alternative provider of general medical services through that process. And I'm pleased to say the timelines are set out here, that following a robust procurement process and an interview panel which took place in February, we were able to award the contract, or make a recommendation to award the contract on the 9th of February. And that's predominantly the decision that we bring to you today. I do want to thank everybody for the work that has happened in terms of leading up through that procurement process to that award, and also the work that we did. The agreement at the board was, providing that was the process followed and the outcome, we would then, because of the tight timescales, carry on with the work until the March board, because clearly you will understand the contract has to operate from the 1st of April. So we had very, very limited time between the 9th of February and the date today, to be honest, to get the necessary work done, including boxing up patient records, looking at facilities, etc., and working with the outgoing practice and the incoming practice to try to get us to a point of, well, to absolutely get us to a point of the facility being available under the Amantawi partnership from the 2nd of April. One of the things that has slightly created a problem in the last 10 days is that we were made aware by the outgoing practice that the Tumble building, this operates across a Tumble health centre and a privately owned building of the outgoing contractors, that the Tumble building would no longer be available because that was an asset which the outgoing partners wished to manage and deal with. I have to thank our estates team who have really worked with us over the last 10 days and the contractors that they've hired to help us to undertake some work on the Cross Hands facility, because it now means that for the interim period, probably until we have the new Cross Hands facility, that all services will need to operate out of the one site. So there's been work ongoing over the last 10 days in the evenings and at night and weekends to try to get us to a point where those services will be as near as possible ready in terms of the building as well. So we are managing that. There are no other additional concerns that I've got at this point in time, and I really just want to bring this to the board for ratification, please, of the decision to award the contract to the Amantawi Partnership from the start of April.
Thank you, Jill. Any questions? Helen?
Just to say that obviously it
Yes,
came
sorry,
as
I meant to say
it came as an urgent service change and a temporary one until the new building came, because there was no other there, and Llais supported that. It's just to say that when we did engage at the very beginning of the Tumble and Cross Hands engagement period, people were interested in the new hub that will be developed in Cross Hands, and I was just hoping that there could be a well-being engagement within that area, showing them the plans again, because they are a bit, not negative is not the word, but is it going to happen? They're questioning, is it going to happen? So I was just hoping that the planning team, primary care team, and Llais could hold maybe an engagement for that community to show them the plans of the new development, and to bring them back on board and to bring that trust back on the new development.
Yeah. Thank you, Helen. So I will pick up that in a second, but any questions on this? No? Okay, so we're content to ratify, which is good news. And Helen, I also was hoping that Cross Hands may have been open before I left, but I don't think it will be, although one of Lee's teams promised me we could even have the business case in May, maybe, that maybe we could have a site visit and have those discussions outside, because the site's still there, even though there's nothing on it yet. Okay, thank you very much. Oh, sorry.
Sorry, it's not about this this item itself, but in general, in regards branch surgeries, Jill, and about GP services and sustainability, which Michael did touch upon. But is this peculiar to us in West and Mid Wales, or are we experiencing this in other areas of Wales and the UK?
I think what I would say in terms of Wales is that Betsy and Haldar have the highest number of managed practices, and so there must be some issue perhaps around rurality, and also possibly being further away from sites of training in terms of tertiary centres and also medical schools, that sort of thing. But I think generally across Wales, if you were sitting in some of the national discussions, everyone would feel that these are issues that are being felt Wales-wide, and they're not just peculiar to general practice. As you know, we've seen a number of dental contracts returned and things as well. So there's a degree to which there is a feeling of unsustainability, which Welsh Government recognise, and in fact I'm engaging now in some new work going forward at a national level to think about how we address this. And the question must be broader, and I hope it will be reflected in our own strategy as well, broader than the models that we find ourselves in now. And it's a sort of form follows function conversation in terms of what's the job that we now need to be doing. And the reason I think the national conversations are also important is because what we wouldn't want to do is create something locally that is bound by a contractual issue that we can't move on. So I think it's going to be some national big conversations actually in terms of services going forward. Notwithstanding, we recognise here that this is a really important part of the strategy that we commenced many years ago. So I think it's time to look at that, but also I would welcome the board's support, I think, in terms of maintaining that engagement with our primary community services, making sure walkabouts and things go out into our primary care as well, and working with us so that we are addressing a whole system piece. And one of the things that I would have added when Lee was speaking about the clinical services plan is that even though we've got a primary community services strategy, we will be absolutely key also to the plans for all of those other services, because they are whole systems, and there will be some opportunities for things to move into primary community services or to think about different models, even as we think about those services going forward. But it's how we invest and resource that support. So back to your initial question, Delith, I think there is an issue around our rurality, but I think that there are challenges on a national basis at the moment, and you know, the industrial action is also happening in primary care as well.
Okay, thank you. Right, thank you. I am going to have to move us on, and I am going to have to speed things up because we do have to lose our chief executive to a meeting about the EMA service at 4:30. So I'm going to move us into the next section, 6 and 7. Now, these business cases have been through all of the committees as well as the reports from the committees, and also been to the executive. So Hugh, coming to you first around the electronic prescribing.
Diolch, Cadeirydd. I'm conscious this is a significant business case coming to the board, but it is part of a national digital medicines transformation programme. Primary Care have got their electronic prescribing system, which is being managed and rolled out by Digital Healthcare Wales. We've got 2 practices that will be piloting this in the autumn. Currently, it's being piloted in Betsy. And that will address some of the primary care integration challenges that we've got between GPs and community pharmacies. This is a health board-wide integrated secondary care prescribing solution, which will enable the transformation of our prescribing and medicine administration processes. 2 suppliers have been put on the national framework for this. One's called Nerve Centre, one's called Better UK. We have, following a process of procurement, we put a competition out for those 2 suppliers and are in a position to award, pending the approval of this case, to one of those organisations, Better UK. The business case itself has been developed collaboratively with workshops and engagement across our clinical colleagues and operational colleagues. It will enable us to work a lot more effectively across sites and between pharmacies and clinical teams. Once both EPS and EPMA are in place, we'll be in a position to integrate fully between secondary care, primary care and community pharmacies. That means that drugs can be prescribed in secondary care and dispensed in a community pharmacy, really speed up the way in which we can discharge patients. Immediate benefits we can see as reduced paperwork, reduced errors. We estimate that EPMA will reduce this by about 2/3 our current medicines administration errors. We'd see reduced harm, litigation and claims. So, for instance, drug allergies will be included within the record, and we'll be able to create warnings for clinical colleagues as they prescribe. And better compliance with our formulary, potentially impacting about 2–2.5% of our secondary care drug spend, which is about £25 to £30 million a year, and reduce delays, particularly around discharges. It will also help us with recruitment. I think increasingly junior doctors coming through the system, they want to see digital systems in place and move away from paper. This is not something that is particularly new or innovative. It is for us, but across a number of organisations in England, this would already be quite commonly found. I appreciate the business case is has a significant cost to it. The cost side, I'm assured, is robust, and having waited for the final procurement to be worked through, we've got therefore robust costings on that side. The benefits, I think, are conservative, and I think we need to push harder at those to realise those benefits fully. But nonetheless, what we have here does represent the net costs as we see them at this point in time. We've worked with Welsh Government to secure funding, and in principle that funding's been secured for next year. We haven't had formally in writing yet, and I wouldn't ask the board to approve this without sight of that. So if we can recommend approval pending that confirmation that funding will come for next year. We don't yet have funding confirmed for year 2 and onward, and that's part of an ongoing dialogue. I don't think we'll get that confirmation anytime soon. So I think we will be left with a risk for year 2 onwards that I will certainly take on and work with colleagues in Welsh Government to try and secure that funding for the longer term, as well as drive harder at the benefits that we see this delivering. This is something that is being discussed and progressed across every health board at this point in time. So I see, we're all in a slightly different place, but I would see this ending up being part of that kind of national infrastructure that we need in digital medicines management. Chair, happy to open it up to any questions.
Thank you very much, Hugh. Questions?
It's not a question. It's, well, I was just checking if anyone else is going to ask it. But there's so given the fact we're being asked to approve it on the basis that we have the funding for the first year, that means this future years there's a potential cost increase to our run rate, which might be mitigated by the benefits of EPMA. There might not be, particularly in the second year. So there is a potential, I understand, for us to pause the work at year 2 technically, because if the funding isn't forthcoming in the second year. Having said that, for all the reasons you said, I really do hope we can progress this work so we can modernise.
Okay, yes, thank you. Very in favour of it.
I do recognise it's a fairly suboptimal position for us to be in, that all we have is assurance of a year 1 funding. That is not where I would want to be, but it is a reflection of where we are.
Rodri.
Do we know if any health boards are hesitant regarding this direction, or are they all, as you said, supportive of and are thinking about progressing down this route?
So I think there will be conversations happening this week with a number of health boards. So hesitant, yes, and because of the significant price tag we're seeing. But having said that, there is clearly a significant benefit, and we know we're going to have to do this at some point. This isn't something we can languish behind without progressing.
Okay, thank you. So the recommendations are to note the business case, but also, can I just check the wording of the second recommendation, because it says approve the business case subject to a funding stream from Welsh Government. It doesn't specify for year 1, or it talks about a funding stream. So should it be for year 1?
Chair, I was optimistic that I'd be able to agree a funding stream that was a permanent one. I haven't got that assurance at this stage. All we have is year 1 assured.
So I have a recommendation for the recommendation. So if we have to say approval funding stream for year 1.
Yeah, I think on the basis, if people were to accept what I said, then I suppose the recommendation is that we approve it on the basis we secure funding for year 1, and that this is reassessed before we progress year 2 and incur cost.
Okay, so we can add that to the recommendation. People content with that?
Thank you, Chair.
Thank you. I mean, we need to move forward on this, don't we? Okay, so moving into the next section, we're looking at the committee reports and some attachments there as well. So we'll move to sustainable resources. Winston.
Yes, so thank you, Chair. The Sustainable Resources Committee met on the 27th of February. A few things I just want to highlight to the board. We looked at the Carmarthenshire model, did a deep dive on that. This is following, we looked at the Pembrokeshire model, the meeting before this one. And sad to say that we weren't assured about the financial sustainability of the existing county model. We received a detailed presentation which covered operational matters as well as financial matters, but we were definitely concerned about the overspending of budgets and the unachievement of cost savings targets. So as a consequence of that, we will be revisiting that model later on in the year. We also looked at the work of the core delivery group and the financial control group updates, and we noted the ongoing work which the group is doing, and in particular the ongoing savings which the group have identified, and we very much welcome the updates. We very much welcome the step change that we can see happening across the Health Board in that regard. We noted the month 10 position. I won't repeat what we've already covered earlier in this meeting. And finally, I think just a few things I want to highlight.
Is that, sorry, Winston, have you finished?
No.
Oh,
I'm literally
sorry.
scrolling through my report because it's 3 pages, this one, so it's not as short as to the point. So sorry about that, Chair. Yeah, we did receive a procurement update, and in relation, we noted about Chair's action and approval of the children's continuing care contract. I think we also, just getting to the end of it, sorry about this, Chair. Yeah, we got positive assurance around the cash position at the year end, but I think you, the Financial Director, has already covered that earlier in this meeting. That's all I wanted to just bring the attention to the board. Sorry about that.
Thank you. Any questions? No. So if we can note that, but also we need to approve the revised terms of reference. Content to do that, and you will note the next paper, which did go to the committee, is there for information. Nothing to add to that, Hugh?
Chair, the procurement paper, it does require...
Oh, yes, sorry,
board
we've got to
approval
approve.
at the end.
Yes.
I'm happy to talk through it, but I think the recommendations probably speak for themselves.
I think so, yeah.
Thank you. So we're asked to, if we look at page 7 of the procurement paper, we're asked to approve the contracts for dental services. Are we content to do that? Support the All Wales sourcing framework contract. Yes. And approve the managed contract for blood transfusion services within the auto-clinical diagnostics to continue. Yes. Okay, thank you very much. Thank you. So we're moving on to the SDoc. Maynard, I know you didn't chair it. Are you going to take this?
I'll open. The report, I think, is fairly self-explanatory. We would draw attention to the fact that there are 2 things to approve. The capital programme for 24-25. It was already mentioned the possibility of a slight underspend on 23-24. But also we need the business justification case for phase 2 to be approved.
Yeah.
In terms of the key risks, there's the GIRFT report on ophthalmology coming back. The IPA, as usual, has services which are not delivering what our patients would have expected. We've already covered the 3-year referral to treatment time in Andrew's report. The regional diagnostic plan is still challenging, as is the mental health recovery plan due to the delay in implementing the multi-referral panel. I'm happy for my colleagues who were there to take questions.
Okay, thank you very much. Any questions? Anna?
Can I just make a request that we try to iron out the wrinkles around the way we receive the GIRFT reports into the organisation?
Yes.
I think we still got a couple of bumps there in terms of how they've flown through committees, so we'll just try and clear that up.
Yes, I was asked the question as to whether the GIRFT report should be going to the Quality Committee, actually, which I would have thought it will.
The report that went to SDoc didn't cover the quality elements of the GIRFT report. It was only on the
elements that sat within SDOC's remit, Chair, so there are probably something we need to look at, but again can pick up with Andrew about we need a written down process, don't we, I think, so everybody's clear.
I think they can be quite broad ranging in their recommendations, so they cover a range, and a lot, and they're quite lengthy and generic in terms of the Orwell's elements of them as well, so I think there's probably just a bit of where to map them again.
Okay, thank you. Michael?
Yeah, can I just add, I chaired the second half of the committee because the A48 was shut.
Yes.
I had to turn up in my swimming trunks, but not ready to go swimming. But we had a very good, I thought, quickly I would say, we had a very interesting debate. Adriana gave us a deep dive on public health, and we had an interesting debate about how to kind of metrics that and quantify that going forward. So I think that was something we want to kind of look further out down the line as well.
Yeah.
That was an interesting debate, and how that flows out and how we can track it and measure it. If it's easier said than done, but I think that was what we're talking about.
Good. Well done, Adriana.
Well, I can't take credit to say it's complex, as all health interventions are complex, but the public health ones even more so.
Yeah, thank you. Lee, do you want to go?
And just one further point, we did have a discussion, you'll see from the update, on a number of regional conversations and plans that are going on, and there's reference there to the thinking we've been doing with Swansea Bay about how we create a more agile team, if you like, to support on regional planning, which is in development, and we can bring up back to board at a later date. But just to note that obviously in the meantime we've obviously had notification from the Minister around the joint committee with Swansea, so that'll be another opportunity for us to progress that.
Yeah, thank you. Okay.
I've got one question, Chair, about the multi-referral panel for young people, especially in light of the last few weeks within the Carmarthenshire area. Can we have assurances about timelines, and when is it expected that this work will progress?
Andrew, is that
Yeah,
you?
I think one of the conversations we had in the committee was around the challenges in getting agreement on the model and the plan with partners, I think. So if I could maybe respond to you outside of the committee in terms of what the timelines might be, or what we're estimating those to be, because as I sit here I wouldn't give you a good enough answer, I don't think.
Okay, we'll include the table of actions, but I would encourage you to speak to Michael, who is chairing the regional children's group, which Ardiana is the vice chair, so there may be a way through some of that. I know it's not only children, it's also applies to adults. Yeah, okay, but yes, we'll put it on the table of actions to get a date.
Can I make a plea that actually it is looked at within Quezac, because there are safety and patient experience issues here. It's not just an SDOG, it's not just a process issue, there are patient impact issues here.
Okay, thank you. We'll note that. Okay, so as well as the report to note, we have the two papers to approve, the discretionary capital programme and the business justification case. So we're content to do that. Thank you. So we now move on to the People Committee. Chantal.
Thank you, Chair. So we met on the 15th of February, and the paper is self-explanatory, but I just want to draw your attention to the committee requested an amendment to the terms of reference, which we are asking the board to approve today, and the terms of reference are present within the relevant papers. And also to bring to your attention that we've renewed the strategic equality plan from 2024 to 2028, but there is a more detailed paper that's coming after this one in relation to that.
Okay, thank you. Yes, and just to note on the bottom of page 3, it should be to update the terms of reference for the People Committee, not the Health and Safety Committee. We are doing a bit of a mess around and see if you notice. So it slipped through the checking.
Yes, that's right.
Okay, thank you.
Just for members of the public, we did have a video for this afternoon that we were going to play as part of the next item, but because of time we've made that available now on the website for anybody to watch that. So apologies to Ardiana, it's just we're vastly running out of time this afternoon, so sorry.
Thank you. Thanks. So we have got the strategic equality plan objectives. Lisa.
Yeah, thank you. So this paper is presented to you. It's our 4-year strategy that takes us up to 2028. As mentioned, it's been discussed in the People and OD committee. It's also been to our staff partnership forum. The paper demonstrates how everyone within the organisation has a role to play in this area. So I'm happy to take comments if anyone has any.
Thank you very much, Lisa. Any questions or comments? No? Okay, thank you. So we're asked to approve this for publication. Content to do that. Thank you very much. We now on to the Health and Safety Committee report.
Thank you. The board is requested to approve the updated terms of reference for the Health and Safety Committee. We've included in attendance the Executive Director of Therapies, we've included Occupational Health and the Assistant Director of Assurance and Safeguarding to be attending our meeting. And then the Health and Safety Committee highlighted the following risks and concerns to the board. The committee was unable to take assurance from a number of the reports, including the Health and Safety Update, the Fire Safety Update, and the Low Voltage Electricity Compliance Update. The committee requested that the reports were amended and brought back to the next committee meeting in May. If the committee is still unable to take assurance, the reports will be escalated to the board. In addition, its item scheduled to be reviewed as part of the committee work programme. Follow-up progress of the various actions identified above will be undertaken.
Thank you. And these will be on the tracker, won't they? Joe, outstanding issues, yeah, thank you.
All on the agenda for next
Yeah. Okay, thank you. I think it's really important just to stress that these reports do need to give that assurance, that they're not there for reassurance, which I know was a bit of an issue this last time. Okay, any questions for Anne? No, we're happy to approve the terms of reference.
Thank you very much.
Thank you, Anne, for what I know was not the easiest of meetings this last time. So thank you. We now move to the committee update reports. Joe?
So thank you, Chair. This covers the rest of the committees that the board has that delegates authority to. So you've got charitable fund, remuneration, health professionals forum, even staff partnership forum and the stakeholder reference group. There's only 2 matters to raise the board in relation to charitable funds. We will be moving directly into a trustee meeting where there are 3 items for the trustee to consider for approval, and we'll also need to ask you to approve the amended HPF terms of reference. And again, just to note, James Severs is now taking the executive lead for HPF moving forward, Chair.
Thank you very much. Any questions for Joe on any of those committees? No, and happy to accept the recommendations. Thank you very much. I'm now moving on to the joint committees. Phil, anything to highlight?
Yeah, you can see there's a bundle of papers which show the minutes of all the various WISC and EASC meetings that have taken place. Some of which I've attended since I've taken on, but some with the previous chief executive, and you'll see that moving into the next item, those fora will be all subsumed into a new joint commissioning committee. But we'll take the first paper first.
Okay, thank you. Any questions? No? Okay, do you want to move us on to the new committee?
Yeah, so you'll see the papers there which relate to all the detail about the establishment of a new joint commissioning committee. There's been a huge amount of work undertaken on this. We've been engaged in that work at Chief Exec and board governance level, and you know the paperwork is all there, but I'm happy to take any questions.
Thank you, Phil. Any questions on this establishment?
Do you need to approve all the recommendations, Chair, on section 4 of that report?
Yeah. Right. Okay. So page 7 then, you'll see a series of recommendations. Are we happy to approve all of those? Yes. Thank you very much.
I should say the reason the report looks a different format to what we normally would be used to is because it's going to all boards.
All boards.
Yeah.
Okay, today, well, in the this round of
this
board.
round, yeah.
Okay, thank you very much. So we then move on to the statutory partnerships update. Jill or Diana, anything to highlight? No?
Nothing that is not in the paper.
Okay, thank you. Any questions on the items on the report? No? Thank you very much. So we have the recommendations there on page 6. Happy to accept those? Thank you. And then there are items for information, which are the Directorate Improving Together sessions, the board work programme, which will be reviewed after today's meeting. And our next meeting will be on the 30th of May. Venue to be confirmed, I think, at this stage. And because we've had the in-committee session, we won't exclude the public to move into that, but we will go straight into the meeting of the corporate trustees, for which you have had separate papers. So I can just move to those. Okay, apologies for absence. Have any apologies? The same as before. Thank you. Any declarations of interest on the items on the agenda? No? Thank you. So if we move to the next stage of the agenda, and we have the first paper, which is the Arts and Health. Sharon.
Thank you. Gosh, trying to keep up. Good. Thank you, Chair. So we took this paper at the last committee meeting of charitable funds. Made it my act together. Okay. So the paper outlines a proposal to build more capacity within the Arts and Health team and to integrate arts into the work of the Health Board to deliver the vision that was set out in the Arts and Health Charter that we approved at our last board meeting. The benefits of this building this capacity is outlined within the paper. The aim is to build some sustainability and appoint a project support officer to deliver a range of projects and to secure additional resources into the Health Board to benefit our patients and our staff, most of which are outlined on page 9 of the report. So the paper is seeking £188,065 of charitable funds to appoint an Arts and Health Project Support Officer to Band 6 against a tapered 4-year financial model. The proposal is predicated on the ability to secure funding as per the Sustainability Funding Plan, making the post fully funded by 2028. The exit strategy is detailed on page 3. And by for year 4, we anticipate that we'll be in a position to cover the cost of the project support officer through external funds. The achievements of the programme to date are detailed on page 4 and 5, and at our last SNMT, at my last professional forum, then we received a presentation on the pilot of interactive singing, visual arts and movement for patients with dementia across the 8 healthcare settings, with over 40 members of healthcare staff participating, and the feedback from the patients on the impact of the activities was very, very impactful and powerful, and quite emotional. So in terms of this proposal, evaluation is a high priority for us, and we'll monitor the impact of the programme, and of course we will share our findings going forward.
Okay, thank you. Some brilliant work goes on in this field. It's just amazing. Very tame prescription programme. I mentioned that to my GP. Quite fancy that. But joking apart, this is really important work. So I'm delighted that you brought it here to us. So the recommendations are on page 16. But are there any questions anyone would like to ask of Sharon? No? Okay.
Sorry. Just from governance purposes as well, just for members of the public to know, this has been fully discussed in our charitable funds committee prior to being presented to the trustee today. It's because it's over the set level that you as trustees need to approve these, Chair.
Okay, fine. Thank you for reminding me of that fact. So are we happy to approve the funding from the charity for this project? Yes. Thank you. Thank you very much. Thank you. So can we move on to the Rondlice General Hospital Chemotherapy Day Unit project? Andrew, are you going to take that?
Yeah, I'll take us. I was going to just say a couple of things. I think I'm conscious colleagues will have had opportunity to review the paper. Yeah. Obviously this is a scheme that's been a long time in the making. It's been a discussion in Ceredigion, I know, for a number of years now in terms of developing a new chemotherapy day unit. This paper presents, you'll also recall that at the last in-committee board I raised some concerns around the tender costs that had been returned that exceeded the available charitable funding that we had at the time for that scheme. Since that last board meeting, the project team have been away and worked very hard to review the specification of the scheme, and I'm pleased to say that they've managed to reduce the shortfall from over £1 million to £389,000 without affecting any of the patient-facing elements of the scheme, which I think is really important in the context of what we're being asked to consider here. Which is for us to meet that shortfall from charitable funds.
Okay, thank you, Andrew. Any questions of the trustees for this? Okay, I just one point. It's not referenced here, but because of understandings to the background, I just wonder if there's going to be a lessons learnt exercise on this. Yeah.
Sorry, Chair, we did ask at the in-committee board that there was an internal audit undertaken, so we can identify any lessons learned for any future projects through that. Just working with Hugh to do a scope that we can then share, obviously, with Andrew as the executive lead.
Okay, and that will go through to the audit committee?
Yes, Chair.
As well. Right, okay, thank you very much. So we're happy to agree with the details that are on top of page 9 in terms of the revised plan, which is the preferred option. Happy to accept that. Yes, thank you very much. The final paper for our consideration today is the review of apportionments of governance and support costs. Who's starting with this? Hugh, is this yourself?
I'm happy to start. I think hopefully the paper is relatively self-explanatory. All three papers were subject to detailed scrutiny at the Charitable Funds Committee, and I think this paper received a significant amount of scrutiny, particularly because of the costs that we are seeing in terms of the cost of running the charity. We do need to undertake a review, which we will do over this year, on the value, the impact and the payback in particular of our cost of fundraising, and we'll report back on that to the Charitable Funds Committee by September, is the date on which we agreed. The allocation then is relatively, hopefully, self-explanatory thereafter.
Okay, thank you. Questions? Eleanor?
It's more of an endorsement of what Hugh just said. When I looked at this, I was quite concerned about the cost of running the charity compared with the benefit it provides and the money coming in. So I'm really glad you're doing a deep dive into that, and I look forward to seeing it coming back.
Okay, thank you.
Sorry, Chair, change the recommendation.
Right, so the first recommendation is fine, which is approve the option 2. But I think there's a revision to the second one.
With the request to undertake a review of value and impact by reporting back to the September 2024 Charitable Funds Committee, which will then be reported back through the board then.
Right, okay, so that's the date you referenced, but we need to include that in the recommendation. Yes. Okay, thank you very much. So I've not been notified of any other business in relation to the corporate trustee session. So the date and time of the next meeting will be dependent on the requirement for the trustees to meet, but there will certainly be a meeting in September, if not before. So that draws our both board meeting and corporate trustee meeting to a close. Thank you very much, everybody, for your attendance and questions, and also thank you to members of our public who have been watching our meeting today. Thank you.